morning, friends. Yes, it's a joy to be before you here. My name is Paul Asimwe. I'm sure most of you, if not all, know me. I lead the men's ministry here at Lueza Chapel, and our chairman for the Fathers Union, Professor Shemerirwe, is here. Please, a hand of applause for him. Yeah. Thank you so much for honoring our invitation to come. I don't want to say you're the ones with bed bugs in your beds because you are able to come early, but you've honored our invitation. And while we look few, my philosophy is that even if only one person is touched by this talk, we will have done our job. So thank you so much for coming. Without further ado, I would like to request our chairman, Professor Tush, to come and open with a word of prayer, and then we will have Dr. Ben Mbonye make a few remarks before we have our presentations by the doctors who have come to speak to us this morning. Thank you so much.
Yeah, thank you, Chair. Let's humble ourselves and we pray. Our Heavenly Father, we thank you for this new day you've given us. We thank you, Lord, that we've all arrived in it safely, and we thank you for the protection that you gave us that brought us this far. Heavenly Father, we thank you for the people who have managed to come. These are the ones you've selected, Lord, to be here today, to listen to what you want us to learn today, Lord, and we thank you. We thank you, Lord, for the doctors who have come to facilitate this meeting. We thank you that you've brought them safely to us here, and we ask that you bless them as they fellowship with us today. Our Heavenly Father, your word tells us clearly that the bodies you gave us, these bodies are temples of the Holy Spirit. Lord, the bodies we have, these bodies are temples where you indwell. And Heavenly Father, we are here to learn how to take care of these temples that you gave us. And Heavenly Father, we ask that you guide whatever is going to transpire here so that we get enough information to look after your temple very well. We ask that what we are going to learn, Lord, you guide us, you give us the wisdom to apply it so that we take care very well of these temples you gave us. Our Heavenly Father, we ask that you bless us as we fellowship this day, and we, whatever transpires, Lord, we ask that it be only what brings glory to your name. For in the name of Jesus Christ we prayed. Amen.
Thank you so much, Prof. Welcome, Reverend Ali. Now, very quickly, I just want to highlight a few other areas of our engagement. After Dr. Ben's remarks, we'll have the presentations by the doctors. We're hoping that each will take about 20 minutes. And then after that, we'll have a Q&A session. And then we'll have, maybe concurrently, we'll see how it works. We'll have a tea break, and then subject to the time that the doctors allow us, we would like to see whether we can have individual consultations. Thank you so much. I would like to call upon Dr. Ben Mbonye to make some remarks. A hand of applause for Dr. Mbonye.
Good morning, colleagues. We praise the Lord for this morning. A few days ago, our chairman called me and said that there was a wish for some advice on men's lives. At that time, he did not indicate that he was going to involve ladies, but I think they must have protested at home and said they also wanted to come. So we are glad to have ladies joining us as well, because the lives are not for men, and you're most welcome. With us this morning, we have got a team of 3 distinguished doctors in their own fields. Here on my immediate left is Dr. Watia. When he came and I started introducing him to most of my colleagues, they all said they know him. I asked myself, I said, I also know him, but he's my colleague, we work together. So you're most welcome, Dr. Watia. And Dr. Jocelyn Webembera is a distinguished cardiologist. She's a cardiologist working with the Uganda Heart Institute, but quite a senior cardiologist. I had not yet asked you. I saw on the social media recently that you earned something from America. Yes. Oh, so anyway, you will tell us what it was. But she's quite a senior cardiologist. She'll be talking to us about problems of cardiology, especially when it comes to our age. Next to her is Dr. Simon Luzige, who is a physician, quite senior, but an expert or specialized in lung conditions. He's also the Chief Executive Officer of Nakasero Hospital. And he's the one who allowed this to happen. And he's also responsible for what is outside there. So you're most welcome, Dr. Luzige, and thanks very much for what you have given us. I think it's important to have this kind of thing because most of the diseases which we tend to get, we get those diseases because we don't know how we should protect ourselves against them. Mainly the lifestyle kind of problems. And there are some which come up as a result of lifestyle, and there are some which come up just because we can't avoid them. But those which can't be avoided also, you can forestall the eventual effect on you when you detect them early. So all that is part of what you should be undertaking. Lifestyle diseases, and also those which can be, once they are detected early, they can actually be handled properly. So it's important for people to be enlightened on some of this, how they should handle their lifestyle, and also how they should keep checking themselves in order to avoid such situations. Let me not delve too much into this, because I think the various presenters will have an opportunity of digging more into those details. Thanks very much indeed, and enjoy your function today. There is something I think we didn't talk about. Those who would like to have some, we came with a team of laboratory fellows as well. They will be taking some samples for various tests for those who would like to screen themselves against various conditions. I think only one is free for diabetes, blood sugar will be free. The other tests which are going to be carried out, there will be a charge, but heavily subsidized, very heavily subsidized. You can pay now, or they take your blood and you pay either by mobile money or they have a machine, Visa card machines. So that then they will send you the results online once you leave your contacts. Thanks very much indeed, sorry. Yes, there's also a dietitian to teach you how to eat. It's very important to know what to eat these days. Okay, thanks very much, and enjoy yourselves. Maybe we'll start with Dr. Watia.
Thank you very much, Dr. Mbonye. I've had the pleasure of working with Dr. Mbonye for quite a long time. He's a very pleasant man. Thank you for your leadership of Nakasero Hospital. Yes, it has made an impact in the country. I like to talk about men's diseases, but I will narrow down to prostate cancer. And I want to tell Dr. Mbonye that the ladies are here because prostate cancer is the most common cancer among men in the world and in Uganda, but more so in Uganda. And it is a disease that has affected almost every family and every individual. And the families have ladies, so I'm not surprised that they are here. So either a brother has been afflicted, a judge has been afflicted, a friend has been afflicted, a husband has been afflicted. So it's a very common condition. And we can't talk about prostate cancer if we don't know what the prostate is. But before we do that, I have seen that many of you have papers with you, and therefore I would like to set just a few questions. If you finish writing those few questions, the answers, you can pass it on to a neighbor if you can. But if you don't have to, keep it, but keep so that at the end of the talk we see if the answers will be the same. These are really popular questions I like to ask people when I'm talking about prostate cancer. Now, my first question is, or my first statement, just say yes or no. Is prostate a disease? You don't have to say it, eh? But just write it down. And a big enlarged prostate, which I see here on radio so much, prostate okugaziwa, is a very big problem. Just prostate enlargement, so it's a very big problem. Then the other statement or question is an enlarged prostate can cause cancer. Then another one, so the fourth one is when an enlarged prostate, which does not have cancer, is removed, okay? You are free, you will never get cancer of the prostate. You become free. Yes or no? The answers are just yes or no. Then the other one, herbal medicine, okay? Be it from America, from where, can it cure prostate cancer? Yes or no? Herbal medicine can prevent prostate cancer. Yes or no? Too much sex causes cancer of the prostate. Yes or no? PSA is a measure for the size of the prostate. Biopsy, taking a tissue from the prostate, can cause widespread of the cancer. So one should not go for it, or should go for it, yes or no? Okay. Thank you. Now, I'll start with my talk. So just the answers will be in what I'm going to say, okay? So the prostate is a small gland, okay, that is below the bladder. And through it, a tube that takes urine to the outside from the bladder, called the urethra, passes. And its function is to produce a milk fluid, and that fluid helps in cleaning the urethra, so it kills bacteria in the urethra. But it also helps in fertilization by neutralizing the semen. The semen is actually acidic until it is mixed with the fluids, because the fluids from the prostate, which have an alkaline solution, alkaline fluid, which now neutralizes the acidity of the semen, and also it helps for the sperms to swim, to fertilize the ovum. And it is very important in fertilization also because the vaginal fluid is acidic, and it neutralizes the vaginal fluids, so that acidity goes and it allows the semen to the sperms to move, because the sperms don't like acid, to move to meet the egg so that they can fertilize. And the size of it is just almost like a small tomato. You know those small tomatoes, the smallest you can think of. And it is also shaped, the shape is almost like that of a pear, okay? And it's a nice thing when we still want babies, but as we age, a few changes happen, and it can be diseased. It can be attacked by several diseases. And it's not only cancer, as people think, because when you talk to people, they say, if this big prostate, once there's a big prostate or someone undergoes a surgery, he had the cancer, okay? So this prostate can get infected. And when it gets infection, that's when we talk about prostatitis. You've heard of that term, prostatitis. And that infection can attack a prostate at any age. They can be children, they can be young men, it can be adults. And I hear, oh, my prostate has become sick when I'm still very young. But it can become sick at a young age, and mainly out of lifestyle when you are still young. But also it can become sick without lifestyle, because bacteria many times, especially during sexual active life, easily settles in the prostate. Many people can eliminate that infection, but some people fail too. And when they fail, then the bacteria remains and it gives it a chronic infection, which you normally term as chronic prostatitis. But also it can become inflamed without any infection. Okay, and can be a nuisance. It's one of the biggest nuisance that we urologists face, one of the most difficult conditions to treat, especially if there is no infection, because it goes on for a very long time. We call it chronic pelvic pain syndrome. Now, as we reach the age of 40, because of changes in hormones, the prostate starts enlarging, and it's a normal. I don't want to call it a normal process, but it is something which happens almost in everybody. It will enlarge. Enlargement of the prostate at times may cause a blockage of the urethra. But sometimes it can be a small prostate causing blockage of the urethra, because the prostate has two types of cells. There is what we call the gland, the one which produces the fluid, but there is also the one which connects or which holds tissues together. It has small muscle fibers. They can increase in numbers, and they have a tendency of being so constricted. So they block the urethra, and as such, you can have a small prostate blocking the urethra, and you can have a very big prostate doing nothing. Okay? But you can also have a very big prostate blocking the urethra. So, those are two problems. Okay? Small prostate, but blocking and giving you all the complications. But the prostate, I said, can suffer from many diseases, but I've chosen only three, the most frequent and the common ones. I've ignored the others. And the other one is cancer, which I said afflicts many families. Now, this cancer is a type that really loves Africans. So, just having the black skin is enough license to be loved by the cancer. In other words, the Caucasians have lesser incidence of cancer compared to us. And on the other hand, we Africans, even if it is an African here, an African who migrated many years ago to Europe, it's the same problem. Our cancer tends to be more aggressive than the ones of the whites. It also is a disease of age. As you age, the incidence crops in. And so, starting from the age of 40, but there are fewer incidences of cancer between 40 and 50, but they are there. So we don't forget to check, and we can be guided by one can have what we call a baseline PSA at 40, and that will guide us as to when and how frequent that person should have a check. Usually, people who have a high PSA in their 40s, chances are that they may actually be harboring the familial type of cancer, which may show up in the future. Now, it also loves families. Okay, if you have had a relative who has had prostate cancer, chances are ×2 that you are at a higher risk than the average population that has not had an incidence. If you have 2 relatives, then it is ×4. If you have 3 relatives, then it is ×6. So the more the relatives, the more the chances of cancer, and therefore many people who have had relatives before should actually have themselves checked up. There is a disease of enlargement, and this we normally term it as benign prostatic hyperplasia. Now that enlargement is, as I've mentioned, an increase in the size of the number of cells. It happens almost in everybody, but it doesn't give symptoms to everybody. But about 10% of individuals between the age of 40 to 79 will have symptoms due to enlargement of the prostate, and the 80% for those who are above the age of 70 will have symptoms of enlargement of the prostate. So you can see how common it is. However, enlargement is not a title to getting cancer. Enlargement itself does not what? Translate it into cancer. It is a completely different disease. It is not the whole prostate that enlarges, but there is a small part of the prostate, actually it's the smallest, where the cells tend to grow big and enlarge and push the rest of the prostate into a cover, so that is that enlargement that you see, we doctors treat and we doctors operate on when somebody has an enlarged prostate. So we actually only remove that enlarged part. What remains behind is part of the prostate as well. It is thin, but part of the prostate, and also that becomes part of the tube that takes urine to the outside, the urethra. So that can become cancerous. And unfortunately, 85% of cancers come from that part. And therefore, removal for enlargement is not a solution to cancer. And I hear that quite often on radios. Okay, genda bakajemu. Okay, so that you don't have cancer. So that's misinformation. You stop checking. You should be checking annually, so that you check like anybody who has never had surgery. So that's a critical thing. I just want to find my order, but my phone is beginning not to move. I'll just continue talking even if it doesn't move. Now, how do we make a diagnosis, or how do we know that somebody has cancer? Okay? Now, one thing I have to tell you is that when the prostate becomes diseased, whether it is inflammation, whether it is cancer, whether it is enlargement, it tends to produce the same type of symptoms. Okay? Because the symptoms are related to the bladder, because it is sitting below the bladder. And those symptoms include urinary symptoms. And the commonest urinary symptoms are what we call irritation of the bladder, or irritative bladder symptoms. So things like you want to go to the toilet to pass urine all the time. You wake up several times in the night to pass urine. And it is very urgent for you to pass urine, you know. You're in a meeting like now, you can't hear the next word. You want really to run to the toilet. If you don't, it will come out, okay? So you want to rush as quickly as possible. And then you get those where obstruction is the issue. You go to the bathroom, if it is a urinal, others are walking away, and for you are still waiting for the urine to come. And when it comes, it's not going where you want. It is actually dropping nearby, and you are at war with your wife, because all the time you are spoiling the toilet seat. Because you don't aim there, it is on the floor and the toilet seat. And when you push, it is coming, stopping, and not coming at once. It is becoming a thin stream, and when you finish, you have to wait for very long. Okay, you have to wait for very long before the drops stop coming, and sometimes they continue, and then of course the smell is not good in the end, because the urine has remained in your panties. You may not realize it, but other people may tell you, or if they are kind enough, or children, sometimes the children may notice that. They may say, Daddy, there's something not right, okay? Because the urine is dropping in the trousers. And therefore, you cannot predict that this is cancer, this is not cancer. However, cancer itself, when it is early enough, those symptoms don't show up. So it is what we call asymptomatic in medicine. And therefore, if you want to detect cancer early enough, you don't have to wait for the symptoms I've talked about. You have to look out to have a diagnosis to be made. Okay? And therefore, that is why we talked about screening, to go early, to be screened. Now, when it becomes later in life, in the stages of cancer, that is when now you have symptoms like blood in urine. That's now a little late. And even the symptoms I was mentioning were also becoming late. And when you start getting also back pains and sometimes failure to move, then the disease is late. So, in other words, if a disease has to be caught early and treated, you don't have to wait for the symptoms. Okay? And therefore, it is so important that starting from the age of 40, you serially follow according to the doctor's instruction. Because there are few cases of cancer in between 40 and 50, the gap of checking is not as compared to 50 and above. Now, since we said there are no symptoms, then how do we get the cancers that are treatable? And to reach that level, let me just give a small explanation of what happens to cancer. Now, cancer usually starts in a particular place, okay? Any cancer starts in a particular place. Let us say it is the prostate. It starts as a small swelling, and then after some time it spreads to the neighborhood within the same gland. That means it increases in size. Then eventually it gets out of that gland. And when it gets out of that gland, it invades the surrounding tissues. Okay? That's what we call local spread. But also it takes ride. It takes ride in the lymphatics, the Nsanjabavu. And it goes to other parts, to the areas. You know, the Nsanjabavu is like when as children, if you ever got wounds on the toes, and then you get a swelling up in the groins. That is the Nsanjabavu. Those are lymphatics. So the first station it goes to is what we call the regional lymph nodes. Then it can take also ride in blood vessels. And when it takes ride in blood vessels, it goes to other parts of the body. One of the first stations that it loves are the lungs, because every blood goes through the lungs. And then it is spread to other parts. But cancer of the prostate loves the bones, because the vessels that connect the bones from to the pelvis don't have valves. And then when somebody is getting disease becoming advanced, he's actually pushing, straining to pass urine, and he's encouraging the cancer to go into the bones. And so one of the commonest stations we look at is the bones. Now, when the disease is still in the organ where it started, that is what we call usually stage 1 and stage 2, okay? And in most cases, that is the disease that can be offered a cure, okay? When it goes out, then that is the stage 3 and stage 4. Now, there, our treatment is angled at looking for the disease where it is. Of course, with the time, we have got remedies that can control the disease for a long time. And that is a different disease. But we should be very much interested in stage 1 and stage 2. And that is why we should be checking regularly. Because stage 1 and stage 2, they are remedies for cure. And therefore, when we are looking for this disease, the first step is asking you a few questions, as you have seen, about your family. We want to know. We want to examine you. We want to feel the prostate, and out of that, we are able to make a feeling of what the situation is, and then we take blood. And when we take blood, it helps us. The blood guides us, plus the finger that we use, especially we put our finger in the anus and we feel the prostate, okay? We may feel nothing, or we may feel something, which may not tally with the blood. So we combine the two to come up with a solution, to come up with a thinking that this is what we should be doing next. If we have suspicion for any reason, guided by the blood, guided by the finger, then that's the when we may recommend that you go for a test. And usually, if one can afford, we recommend the MRI scan. Why do we recommend the MRI scan? It helps us to know exactly where to take the tissue from, and it also helps us to know if there is any spread of the disease. Because after taking tissue, it may confuse us when we do the MRI later on if we are to stage. And it is also helps us in reducing the numbers of biopsies, because PSA means prostate specific antigen. It is specific to the prostate, but it is not a diagnosis. It's just a guide. So it may be high for different reasons. If there is infection, enlargement of the prostate, if there is injury to the prostate, it may enlarge. I mean, the PSA may be high. So we just use it for the sake. I mean, we use it to guide us in what we do, also to guide us in the severity of the disease. Then we take a tissue and we send it to a pathologist. The pathologist reports to us, and then we sit with the patient and decide on the way forward. If there is a cancer, or if there is no cancer, then we tell you, but don't forget to keep checking regularly. If there is a cancer, then we agree on the modalities of treatment. Okay? And the modalities of treatment are there for cure. Okay? The modalities of treatment are there for cure. There is surgery. You sit and agree. If you want surgery, yes, you go for surgery. If you want radiation, and there are different types of radiations. There's what we call external beam. That one's from the outside. There is what we call brachytherapy, where you put the seeds in the prostate. And even the external beam, there is what we call the stereotactic. That is highly selective. You have heard of the cyber knife, okay? That is highly selective. So it is aiming at only the lesion. And then, if the disease is widely spread, then there are other modalities of treatment that we put in, including hormones, including chemotherapy, including radiation, so that we can control the disease. Now, the choice is always to have stage 1 and stage 2. And therefore, it is very important that we take on this campaign of testing ourselves regularly, so that we can have the appropriate treatment. And thank you very much. And I should say you should inform others so that they are aware of this regularity of checking. Thank you very much.
Thanks very much indeed, Dr. Watia. Now call upon Dr. Ruzige. Ladies last. Dr. Ruzige she will be needing the screen, and I thought would have to reorganize and go, and so we can face the screen.
Thank you, Dr. Mbonye, and thank you, colleagues. Good morning, and thank you so much. We'd like to thank God for this opportunity to have this conversation. As a doctor, the best opportunity I have to make a great impact on my patient and the family is when a lot of things are still within our means. And Dr. Watia's example is one of those, like the staging of the cancer. So even me as an internal medicine physician, I know most of us here refer to us as physicians, but if you go to America, you hear them talking about internist. Internal medicine physicians are called internists in America. For us who are aligned to the Commonwealth and the Queen and the King, now it's the King, you'll hear us being referred to as physicians. Who are physicians? Physicians, in simple terms, are doctors who deal with complex matters of the adult patients, or adults generally. I don't know why they use the word complexity. It's because we don't see what we are doing quite often. So we rely a lot on intuitiveness, our conversation with the patient and the family, and then adding labs and tests. And quite often, these tests don't come randomly. There's a thought process to it. When I ask you to go and do a urinalysis, there's a reason why I have arrived at that conclusion. I'm not asking you to go and do a sputum test. So there's a lot of thinking, there's a lot of analysis, there's a lot of inquiry. We actually more or less like investigators. We operate a lot to a mode of a CID, but this time we are asking you, at least we are in a good room where we are talking. There are no windows that are in the ceiling. The doors are open usually. You can see outside. So we are talking with the patient. So as internal medicine physicians, our job is to look at the adult health. And in adult health, interestingly, and for us in regard to this conversation today, we categorize adults, those below 65, and then what we call the older adults above 65. Interestingly, the two are not the same people. If an adult of below 65, for example, gets a chest infection, the implication of that chest infection on that person is different from somebody in his 70s or 80s. And it's very important for us to recognize that. I may admit a patient who is 70 and actually give somebody oral antibiotic, somebody who is 55, and you go home. But for the same diagnosis, I retain one, the other one I tell you, let's see you after 2 weeks. So it's very important that we appreciate that difference. So from the internal medicine perspective, in general, our interest in adult patients is usually looking out for things that we can make good, or things that we can help the patient improve, and with the target of improving the overall quality of life and preventing some of these very complicated conditions. One of them is, of course, related to cancer. Specifically in men, besides the cancer of the prostate, we also are likely to have any other cancer. As a chest physician, we'll be looking at cancer of the lungs. We also have the commonly known cancer that affects both genders, is the colon cancer. You've heard of the colon cancer. Now, cancers are very common, as you can imagine. Interestingly, most of them are also age-related. Although the prostate is more strongly related to the age, the other colon cancers, for example, may not necessarily be waiting for the older adults. It can start at a slightly younger age compared to the cancer of the prostate. The lung cancer has a lot of influence from the environment. When we're studying, as medical students way back, they used to tell us once you have a gene, your gene is determined. But as time has come, and I remember my old Professor Biarugaba, the genetic doctor, he introduced to us a concept which it's now that I'm beginning to realize, the concept of epigenetics. When we're being trained, they said genes cannot be changed. But now we are aware that genes can be influenced by the environment. As you can see, two twins, one raised, both born in Uganda, one raised in Uganda, one goes to the UK. After 10 years, the two are not the same people in terms of behavior. And so epigenetics. So the environment affects us. Lung cancer is one of those cancers whereby the environment impacts. So the quality of air you breathe in, your occupation, your habits. For example, if you smoke, the risk for cancer of the lung is different from somebody who has never smoked. If you worked in a cosmetic industry, the risk of cancers in somebody in that cosmetic industry is different from somebody who has never worked there. So these are all things that can affect our genes and make us susceptible to different conditions in a different way. So as physicians, we are always interrogating patients. So when you come to me for a health check, for example, we'll be looking at you from head to toe, inquiring and trying to see what is happening inside you. The common things people worry about are usually kidney issues, liver issues. All these things are impacted by what we consume, especially things like alcohol, for example, will impact the liver greatly, or medicines that sometimes we give you will impact the liver and the kidney. You may have one condition, I'm treating that, but that treatment may affect your body in another way. So when you are coming to see an internal medicine physician, he or she is likely to open up all these conversations. And that's why the internal medicine physician consultations take a little long. And normally I encourage patients, if possible, come with somebody else. Because there is a risk of us giving too much information or ask you so many questions and then you lose focus. I actually encourage patients to come with somebody. So in my consultation room, there's always one chair and there's always an extra chair outside waiting for. The more people I have to have a conversation about a patient, the better for me, but also the better for the patient. So what you consume may affect. So some of these drugs and medicines we prescribe for you, we are aware of their potential risks. So we are interested in them. So when you are asking patients to come, please come with your drugs. Come with all the herbs you have been taking. Come with all the medicines sent from abroad. Some of your family members may send you supplements. Come with them. The doctor is interested in looking at them. We quite often take a lot of multivitamins. These vitamins and minerals, the body requires them in very small quantities. That's why they are called micronutrients. If you load too much of them, it's also a problem. So bring them. Even if they are multivitamins, bring them when you're coming to see the doctor. So we, as internal medicine physicians, as you can see, looking at the whole body, putting those in perspective, we try to interrogate you along those steps. But there are two issues that I would like to maybe use this opportunity to bring out because of time. Is one, the issue of health checkups. At least have a scheduled health checkup every year. Scheduled for health check. So once you clock 40, generally, there is a lot of changes that happen in the body. So I encourage patients to have a health checkup. And the word now we normally use is wellness. And again, back to what Dr. Wati had just said, don't wait for symptoms. If you are doing well, you feel you are energetic, you feel you can run many kilometers, that's the time we want to check you. And hence the word wellness check. Don't wait to come to me when you have a headache. That's a different consultation. So have a scheduled wellness checkup as part of your activity. If possible, calendarize it. Doing that is one of the things that is going to improve or increase the chance that me as a doctor, as an experienced physician, may have something that I can do to impact positively and not wait for you. And then I come and say, no, you have chronic kidney disease, now go for dialysis. Now go for kidney transplant. There I would have missed the opportunity to prevent that dialysis or to prevent that transplant. So scheduled wellness checkups are very, very critical for us because they give us an opportunity to interrogate your system without running too fast, trying to chase things. So here we have time to investigate things systematically. And when you come, we go systematically. There are some tests I'll request for somebody who is 40. There are some tests that I'll request for somebody who is 80. They are different in some aspects, and the targets may be different. So wellness checks are very important. And then now the other thing that I also want to use to put in as an internal medicine physician is health promotive activities or services that I have seen are not well consumed in our environment. And yet, what I have seen in some of the places, I've had an opportunity to at least work in Australia, train in the US. There are some health promotive activities that people consume, and they're in policy that we have not yet started here. But you see, as the country has changed, I think it's very important that we adopt some of these good habits or good behaviors, if there's such a word. And these are things, for example, issues of vaccines. Vaccines. You have heard of the word flu shot. You have heard of a pneumonia vaccine. Interestingly, as you grow, the reason you are going to come to hospital or to be admitted as an older adult, either because you have a chest infection, or you have a bone problem, or you have a urinary problem. Now, chest problems can be minimized by vaccination. The way we vaccinate children for different conditions, as we grow, our immunity also needs to be boosted. And we really, really want to emphasize this point, especially for people above 60. And for people above 40, if you have diabetes, you have high blood pressure, you have extra weight, you are obese, these are a very, very important sets of intervention that can help improve overall health. So, issue of health checkups and then the vaccine issues. Vaccines must be consumed must be taken up because of the implication they have on the body. Luckily enough, most of these have been tried, so we have a lot of experience. It's not like the COVID vaccine that came and we had to do something because we had to do something to help. But pneumonia vaccine, for example, the flu shots, there's a lot of experience that we have and we are very comfortable with them. The flu shot is taken every year. Every year. If you have diabetes, high blood pressure, anybody from the age of 40 should have it. If you don't have any of those and you're 60 and above, you should have it. The pneumonia vaccine generally, if you're above 65, one shot is enough. Especially there is a special type called the Prevnar 13 that is well managed to boost the immunity to stay longer, sustained. So those vaccines, I would like to encourage us to consume them. And then health checkups for us to be able to pick up conditions like diabetes, high cholesterol issues, thyroid problems, salt problems, hypertension, and then the condition that my colleague, Dr. Jocelyn, is going to talk about, the cardiovascular conditions. I want to leave that for her. But on my side, there are conditions that I would like us to emphasize. The cholesterol issues, the thyroid problems, and then, of course, the screening for cancers generally, which we can ably do when you come for annual health checkup. The checkup includes screening for cancers, and these are targeted for men and for women. Men, of course, as you may read and you may hear, we are very shy, and we are victims of our own selves, because sometimes the upbringing that we have that men are strong, men are less likely to seek for health. Quite often, I want to declare here that most men I've seen who have come for annual health checkups because the madam has said go. Go. So and that's why I'm happy to see the ladies here. And quite often they are our advocates. So please, let's not fight them. Let's support them, the ladies. And I really want to appreciate the ladies. Now, yes, including myself, I now have a glass that was given to me because my wife insisted, this month you don't come back if you don't have a glass. I used to read like this. And so patients, one time my wife said, but doctor, what are you doing here? So I said, I'm going 1 year. And then after that, I had an appointment, and they were calling me that you have an appointment with the eye doctor. So you can see the complexity, even me as a physician. So ladies, I really appreciate your effort. And the other thing which I would like to take this opportunity to maybe bring to the audience, which I've seen and the challenge for us internal medicine physician, is the concept of alternative medicine. Alternative medicine. I'm not talking about Dr. Mutula Kungongaba Road or something like that. I'm talking about people sitting in labs and looking at things that is supposed to impact on our lives. besides the usual traditional medicine that we know, that me and Dr. Mbonye, Dr. Wati, and Dr. Jocelyn trained in, the so-called alternative and complementary medicine. I'm sure you have heard that. It's a huge, as an internist, we take it with a lot of openness, because there is also a lot of evidence around its support, especially in areas that are very gray. Diabetes. We know when we're training, they used to say diabetes cannot be cured, but we also now know that diabetes can be cured. Okay? Hypertension. So there are these alternative approaches to medicine that have come up, and I want us to be open. Please, when you hear of one, bring. You've heard about stem cell treatments for patients with stroke. There's a lot of science going on here. So me, as Dr. Ruzuge, I cannot say it doesn't work. I have to listen. So in fact, I'm taking a personal study to help me inform myself, but also maybe guide my patients. So when you hear of these alternative approaches to medicine, it's very important that you come and discuss with your doctor. The doctor may have actually had an opportunity to review it and give you, don't keep it under the carpet, and only show doctors the medicine that you think the doctor would like to see. So the concept of alternative medicine and complementary medicine is a big thing, and it's affecting men's health. And for us men, some of these subjects we discuss related to Dr. Wacha, for example, erectile dysfunction. That's where these things have gone a lot. Weight loss. People are using a lot of alternative medicines and complementary medicine to control weight. Because doctor said if you control weight, it will help control your pressure and also control your diabetes. Now, if instead of swallowing tablets every day, why don't I try the other method, which I've also been shown to? So these things come in the mix. I want to tell you that we are open to these conversations. Don't hide them. In fact, bring them and we discuss them. So alternative and complementary medicine, we are aware. And we are also trying to evaluate them internally and see whether we can either add them to our treatment options or guide our patients on when and when not to use them. So please keep that. And then, of course, along that, I just wanted to say something in regard to what Dr. Wacha said. In other aspects of cancers, for example, cancer of the breast, which can also affect men, okay, and women. It's one cancer which we are aware that once you take away that, then you have removed the organ, then the patient is less likely to get cancer, which is different from the prostate. As Dr. Wacha said, what they remove is the part of the prostate. Now, for the breast, it's a different story. You can actually, if you knew the family history, the risks, the patient can undergo breast removal. I'm sure you have heard so many celebrities undergoing elective breast surgeries. You know, a lady gets breast surgery, they remove all surgeries because there's too much risk of breast cancer in the family. And once you remove the breast, you have removed the house where the cancer would have started. So the risk goes away almost 100%, which is different from us men with the prostate. Okay, so I just wanted to because Dr. Wacha brought it very nicely, the issue of prostate, removing part of the prostate does not mean that you're free from the risk of developing cancer. This is different when it comes to breast cancer, and maybe even the ovary and the uterus. Once you remove the uterus, you remove the house where the cancer would have sat. So as internal medicine physicians, our job is to try and support surgeons. The treatment Dr. Wacha will give you, for example, may affect other systems. So we work together. We work together. We rely a lot on interrogating you. So give us as much information as possible. Whenever you're going to see the doctor, carry everything. We rely a lot on lab tests because we're trying to look at the assessment of the body internally. We rely a lot of imaging and other modalities of testing. That's why we'd like to thank Dr. Mbonye and the founders of Nakasero Hospital, because at least we have one house or one roof where we have all these things done, and you don't have to tell the patient, go here and here, apart from one or two things that we'd like to also improve in the coming future. But at least I can comfortably assess my patient in one house, under one roof, and have you to go home when we at least have idea of what is happening. So please, my plea to you is the scheduled visits for wellness. Don't wait for the headache. Don't wait for the tummy. Don't wait for that moment when you have blood in stool. Come and have it scheduled. Let's agree with you when you're going to have your next test. Is it after 1 year or 2 years? There, I have an opportunity to help you manage and prevent so many things. Outside that environment, it will be very difficult for me to make meaningful change. When conditions have appeared, then we are all doing a lot of damage control other than trying to effect cure, which we can actually do cures for some of these conditions. Thank you so much.
Thanks very much indeed, Dr. Zige, for that elaborate presentation. Just a small correction. It's not true that physicians help surgeons. Me and Dr. Watia are surgeons. Jocelyn and when they get stuck with certain conditions, they call us to come and help them to bring it. We physically cut them out or fix them physically. So jokes aside, we are complementary to each other. The physicians and surgeons work together. Now, we have Jocelyn Rwebembera, who would like to have now to present to us. Jocelyn Rwebembera is a senior cardiologist, and I'm sure we'll be talking about people with broken hearts and things like that. We are going to have to shift because she would like to screen most of our presentations. So those who are sitting on this side, that's why we left her to the end so that we can shift to one side. We'll organize our seating so that we can face the screen. So where are you going to put? Where are you going to put? Can we shift?
Okay, no, this is fine. Okay, thank you very much, Dr. Ben. I was just telling Dr. Ben that the pulpit of here is taller than me. So I will use here. So good morning. And thank you very much, Dr. Ben, for the invitation. I'm really glad to be here. It's my first time in this chapel, but there are many familiar faces in the audience, so I really feel at home and glad to be here. So I'm going to talk about cardiovascular health, and you know that put simply is talking about the health of our heart and the blood vessels. So I just thought to put a quick picture, a video of our heart. You must have, all of us have seen a heart. Most of us, it would be animals' hearts, but they really are similar to the human heart. And this is how it started doing this from when you were in your mother's womb. And it doesn't stop even when you're sleeping. And It's pumping, it's supplying blood to those blood vessels, and those blood vessels are going to take the blood to the rest of the body. This is the big vessel. Do we have a pointer? Okay, it's fine. We have the big blood vessel, that's where like my finger is, that one which takes blood from the heart. It will give off branches as it goes along the way. And then that is, I just wanted us to show how the blood moves. So there, that blood is coming from the lungs. That is the main chamber of the heart, which is then going to supply it through the blood vessel. That is going to be very important as we get to think about, okay, where is the disease and how does it start? So that's very important to keep in mind. I wanted to show us that when you saw each branch going off, finally, each of our body parts, so from the brain to my arm to my lungs, my kidneys, my leg, you know, all those vessels go when they branch off, okay? So finally, it's like a tree that is going to each organ of the body, a tree that is supplying every part. So of course, the vessels start off bigger, and then they get, as they branch off, they get smaller and smaller. And I also wanted to show this open slice picture, okay, showing if we sliced that blood vessel, how does it look? As you can see, it's crisp clean inside, okay? And that is how our vessels are when we are born. They are very nice and clean. But then what happens as we start to grow? Okay, so my talk, when we talk about, you know, you hear about these problems, someone has got a stroke, someone has got a heart attack, someone has got, their leg has been removed, you know, it sounds like many problems, and people will be like, oh, that's, you know, the problems are too many. But I want us to actually realize that this is almost one disease process that is happening in different parts of the body. And so common strategies can be able to almost control or prevent many of these problems. So that is how clean our blood vessels are when we are born, before any, you know, dirty things get into us. But then, this is what happens. So this is the clean blood vessel. Those are our cells, like when you do your full blood count and you see red blood cells and other cells, they are there. Now, this thing in medicine, we call it plaque. But in simple words, it's, you know, dirt which is building up, okay? Of course, it's given a yellow color because one of the major contents is cholesterol. But it's not the only content. There are many other things at play that, you know, build in that lesion. And of course, it will start off small, but it keeps on growing and growing if we don't do the checks to, you know, control our cholesterol, stop smoking, control the blood sugar. So that is plaque, which is building up. And so this is how it is. That is how initially the vessel is wide open, but then it starts building up. When I prepared this PowerPoint, I was with my children, and they looked at this, and they're like, oh, it looks bad. And I said, okay, that's the truth. Okay, you know, it's easy to look on the outside, and I'm like, okay, you know, your legs are not clean, your what? But even inside where we are not looking, it's the same process, okay? So the fact that we are not looking there doesn't mean everything is okay. We need to keep it in our minds that if we don't do the right thing, that's how things are going to build up. Of course, here, this is a video showing it in a short time. Many times it spans years. This can take 20 years, 30 years, 40 years, 50 years to build up. Okay, and that's what I'm saying, that this process spans years, and it is right from birth. It doesn't start when we clock 40 years, okay? This is one difference I have from Dr. Watia. It doesn't start when we clock 40. It starts right from birth. Not even right from birth. It starts when we are still in our mother's womb. So that what the mothers do when they are pregnant has a very big impact on what happens to their children. But now, taking our personal responsibility right from when a baby is born, this process actually starts. Okay, so I'm saying it's the same vascular system. Vascular is blood vessel system, but often the disease process is the same. So starting from here, I'm showing this is the brain, and you'll hear that, someone has got a stroke because we have those blood vessels. I should be able to find my laser pointer. Thank you. Okay, so this is the brain. We talk about the legs, okay? That's one, the general population often knows two things, stroke and heart attack, okay? But wherever these blood vessels are going, so this is going to our legs. You may have had people, it's not a common word, but, peripheral artery disease. So someone starts saying, when I'm walking, I feel pain in my calf, okay? Then I stop to rest, it stops. And ultimately, someone can even lose their leg just because of that process, because once that vessel goes on blocking, once there is no blood supply to a part of the body, it will die. That's the bitter truth, okay? The rest of the person may be alive, but one part can die, okay? This is showing coronary arteries are the blood vessels that supply the heart. Now, our heart supplies blood to the body, but the heart itself, it also needs to get blood. And that is very important. So these are the arteries. We're going to look at, I think in the next slide, whereby if that artery gets blocked, that is where the heart attack story comes in. This is the aorta, that big vessel that supplies blood to the whole body branching off. But that artery also can get problems. Also, when that plaque keeps on building up, when that plaque builds up, actually the blood vessel becomes weak. It doesn't become stronger, okay? It becomes weak, so it ends up sort of ballooning out, and many things can happen. The kidneys. So what here I wanted to show that many of these things we hear, it's actually the same disease process from head to toe. It's about the blood vessels that are not taken care of very well. I wanted to clarify two things. I know often people come, someone says, oh, I went, they told me I have angina, okay? Then the other one is they told me I got a heart attack. So what is the difference? I'll come here. So as we said initially, when you start narrowing, you see that is maybe a 10% narrowing. Here, this is, let's call it a 50%. So initially, when someone is, let's say here, okay, remember, when your blood vessel is wide open, God knows it, that for your leg to get enough blood or for your heart to get enough blood, you need a blood vessel which is, so many millimeters wide, meaning you need it to be fully open. But now, when you're seated, like now, because you're not consuming a lot of energy, even if you are at, 50, 70% narrowing, the blood that is going through that narrowed lumen can still be enough, so you're not complaining. But if I said you climb stairs and go to the sound room, then that's when the heart will complain that, you know what, you're making me exercise, but you're not giving me enough blood. So that's when someone will say, oh, when I'm walking, climbing stairs, I feel chest pain, and I need to stop. And when I rest for about 1 minute, I'm okay, and I start walking again. Now, then someone gets to know in their mind that this thing comes when I climb stairs or when I walk uphill. So what do we do naturally? We downgrade our activity. Instead of going for the health check, okay, I will start avoiding stairs. I start taking the elevator, or if I want to go there, I would rather walk around this hill. The challenge is that people will not take off their time to say, let me go to the hospital, until it's a total breakdown. And that's where the problem is. Because if you came when it is, 70%, you've not gone into a heart attack. It is manageable without major complications, okay? Now, what is a heart attack? A heart attack is when we get total occlusion. Either the cholesterol, that plaque itself, has built up to, 90%, or it may be at 80. You may have been, surviving on that little lumen, and what happens, sometimes you get a little crack, okay? And, any crack inside our body, just like if I got a cut here, I got a cut, naturally my body, to control bleeding, will form a clot, okay? Even if it's a small cut with a razor blade. So also once again, this plaque, as I'm saying, it looks bad, it looks ugly, but it's also, it's not strong material, it's friable, it cracks easily, okay? So once you get a crack, let's say you are remaining with a 20% lumen, your body will form a clot. And that is when someone says they went to work, they were okay, and in a space of 5 minutes, a lot of chest pain. The other time the pain was coming and they could sit down and it would go away. This time this pain comes and it just can't go away. So that is what we call a heart attack. Basically, it's a total occlusion. That part of the heart has no blood supply at all. Okay, I was here saying it's the same disease process. This is a stroke, okay, showing you get this, again, this blockage, the plaque building up, like in these blood vessels of the neck, and a piece of that dirt can break off and go to the brain. Or you get that plaque directly in the blood vessels in the brain. That is a stroke. This is a picture of blocked arteries in the legs. Actually, this is a CT scan of a real patient we managed. So this is not just taken from the internet. So while you see that this is our big vessel that is coming down the aorta and branching off from this picture, you can see that here, it just stops there. You don't see the blood vessel continuing. So this person had come, this was actually in both legs, but one leg, this leg was, we had to remove it. It was lost, unfortunately. But the story was dating back to this thing has been going on. I've been feeling pain in the legs. So it means this blood vessel was totally blocked. Okay, then the other question that people often ask is heart failure. Okay, what is heart failure? So in summary, heart failure is an endpoint of several disease processes. It just means the heart has failed, okay? And what happens is that our heart on the left, I know bullets normally are not called beautiful. The one beautiful bullet is the heart, okay? If you see, it is supposed to have that shape, a bullet shape, and normally, we know traditionally, if I said, oh, Mr. So-and-so has a big heart, we mean someone is generous, it's a good thing. But in real life, a big heart is not good. The smaller the heart, the better. Okay? So, our heart is supposed to be this nice, we call it a beautiful bullet shape. But what happens in heart failure, okay, I'm really simplifying this. You can also get heart failure when you have this bullet shape, but that's a don't worry about that. Most commonly now the heart loses that nice, beautiful shape. It becomes like a flabby balloon, okay? And if I showed you a picture when this heart is beating, you'd see that this is like a flabby balloon just seated in the chest, almost not doing any work, okay? The duration over which this develops varies. For example, if someone got a heart attack, the heart can move from this picture to this picture in 2 or 3 days. If someone got a huge heart attack. But there are other conditions like high blood pressure. If it's not treated well, it will also lead to this, but that will develop over years. Okay? So someone says, they told me I have pressure, I used to take drugs, other times I would forget, but now they've come saying, I'm short of breath, I can no longer walk from my bedroom to, to the living room. And when you get to check, you find the heart is like that. So that duration can vary depending on what is causing it. There are other things that can cause this where we may not have a lot of control, like some women give birth and the pregnancy really, damages the heart, especially multiple pregnancies, so they can also end up with such a condition. But high blood pressure, heart attacks are common things that will damage the heart. So what happens? What factors are at play? These are things that we know. We shall not read each picture, but I just wanted to know, broadly, we can classify these things. There is what we call modifiable and non-modifiable. Modifiable means we can do something about this. Most of the things here, or all of the things here, we can do something about them. From high blood pressure, salt taking, sedentary lifestyle, smoking, obesity. I'm going to talk briefly about obesity because this is a big problem. Almost each one of us here is affected, even if not only you, if we talk about brothers, children we've left back home, it's a big problem today. But then there are those which are not modifiable. You may not do much about them. First of all, male sex, okay, increasing age. Just like Dr. Watia said, when it comes to the prostate, there are genetics at play. So there's a familial preponderance. If someone in the family has got a heart attack at an early age, like before the age of 50, there's a high chance that there are genetics at play. And then there are things we know, but there are things that we don't know. Why do we say this? There are patients who come and someone is totally clean. Very thin, cholesterol is normal, pressure is normal, everything is normal, but someone has a huge heart attack in front of you. So that we don't want to say that we know everything, but those cases are few. 90% of the time, we can be able to identify the risk factors. Okay, I just wanted to shed light on overweight and obesity because it has become a global pandemic. It is a very big problem, and if we don't do something about this, it actually cuts across almost, all specialties, including Dr. Ben, who is not presenting. But talk about orthopedics, overweight and obesity is a major risk factor. Talk about prostate issues, overweight and obesity, internal medicine, it cuts across. One thing, one simplest way to talk about weight, being overweight, being obese is what we call the body mass index. When it comes to the doctors, they'll know that that is an oversimplistic way. There are several other things we look at, but body mass index for the general population is something to look at. This is a measure that factors in your height and your weight, okay? In essence, it is saying if you're taller, you have an allowance for a bit more weight compared to someone who is shorter. So here we are showing, what is the normal, typically 18.5 to 25, and it is showing all the range up to severe obesity. I believe that today out, we have an opportunity to be able to do our heights and weights, and we can be able to work out the body mass index. Again, that is an oversimplified way, but it is at least a starting point. But just to know that, previously, like all of us as we studied, in medical school, they told us, body mass index greater than 25 is obesity. But we know that today it is different. It had always been, put across as it's a matter of weight, just reduce what you're eating, exercise more. It's not as simple as that. It is something very complex, and it is a real disease, okay? Of course, as we say, that there are genetics at play, but also epigenetics, as Dr. Luzige said. One statement that I often use to explain to patients, okay, is that the genetics load the gun, but the environment pulls the trigger, okay? And the challenge is that today we are in an environment which is just pulling off all these triggers. Difficult to control, but one thing is that there are many genetic factors. It's a chronic disease and it's a real disease. It's not a matter of telling someone, please reduce your food. It's not as simple as that, and it's a real disease. So this helps in the way we look at people or individuals with obesity, and also to know that it's a problem that people need to be helped. The stigma, the keeping them away is not going to solve the problem. Parents have come to me, and a parent really says, you know what, Jocelyn, it's even hard for me now to walk with my son in society, okay? Because it comes with a certain stigma. It comes across as you're careless, okay? That's the quick judgment that comes in people's minds, but it is not as simple as that. So if we can understand that, we shall offer the help that people need. Obesity at the age of 2 predicts the status at age of 35, and we know that today we have an increasing, even in pediatrics, it is an increasing problem, very big problem. And the World Health Organization predicts that by 57% of today's children will be living with obesity at 35 years. Okay, so actually these children you see who are obese, and I know Dr. Ben had said these are men, and I said yes, but these men have families, okay? And if our children are not doing well ourselves, okay, it will not, help us to live well or, to go down to our graves in peace. Okay, with a gray hair, you want to go down, calmly and peacefully. But one thing is that obesity, even in children, in our families, we need to support these people. It's a heritable problem many times. I know people have been saying, but look how small I am. How come this child? And parents are screaming at children, okay? I told you to stop eating those things. Number one, we are the ones who are providing those things, okay? But even beyond that, I want us to know that it's a medical problem that just talking will not solve it. Obesity is related to more than 200 diseases. It's actually, it's a disease itself, but it's also a gateway. And now when you look at that, I can ably say, I was just thinking as Dr. Watia, Dr. Luziga were talking, almost every problem they've talked about, you can find it under here. Okay, so ranging from, the brain, mental status, talk about almost all cancers. Dr. Luzige, breathing problems. Dr. Ben, arthritis, people crying arthritis at the age of 30. Obesity is a major risk factor and it needs to be addressed. But also, very importantly, when we come to the heart. So we need to address this. I thought to talk about this because one key thing is that parents are keeping away children. Parents are feeling like, I can't take this child to the hospital just because of obesity, or they are thinking this child is not doing enough. So even the individuals are feeling like it's my fault, I'm not working hard enough. But we need to be supportive. We can leave go of that. So finally, what should we do? I know everyone's thinking, we've talked about the heart attack, we've talked about stroke, we've talked about obesity. So what is the take-home message? There are many things that we can talk about, many things that can be done, but this provides a very good summary. It's called Life's Essential 8. It's a summary of things. Although it was developed for heart problems, it actually cuts across. That's why it's even called Life's Essential 8. It will help, your mental health. It will help your breathing. It will help everything else. So number one is about our eating. And if you read the details there, we know we have a dietitian outside all the eating, in terms of how much carbohydrates, how much fruits, how much vegetables. The second one is being more active. Of course, being sedentary is not helping us at all. And being sedentary has nothing to, when we talk about a sedentary lifestyle, don't look, at the person who is obese next to you. Even if you are thin, but you are sedentary, it still has a lot of impact on your life. Of course, quitting smoking, getting healthy sleep. That is one key thing. Until about last year, these were called Life's Essential 7, but there's an addition of healthy sleep. That is what has made it 8. So enough hours of sleep, and that is lacking today a lot because of all of us are busy. We go to bed at 2, we are waking up at 5. So that really needs to be addressed. Managing our weight, as we have seen, will solve so many problems, or at least control. Then controlling cholesterol, but you cannot control it if you do not know what is your cholesterol level, first of all. So that is why we said we have an opportunity today. Let us have that cholesterol check done, and then a doctor can be able to advise. Managing blood sugar, first of all, know what is your sugar level, then you can take the advice of what should I eat, how much sugar should I be taking, and finally, managing our blood pressure. This is available. I think I was telling, I gave this talk to my son's class, like the teacher invited me, and I told the children that this is something you should ask your parents to print and, put in every bedroom, put a plug on the fridge for everyone to look at and for us to keep reminded. It's available in various, there's a format for children, which you can easily download, and there's also a version for women. Thank you very much. I think that is it.
Thanks very much indeed, Jocelyn. So I think that was quite actually deeply detailed. Thanks very much indeed. I hope we were able to pick quite a lot. Should we go into question and answer now, or we have a tea break? What should be done? Running a bit late though. How much more do you want to give us? I hadn't noticed your the Q&A. Maybe the presenters should come forward again. And at this stage, I think we can redistribute ourselves as we were earlier.
A hand of applause for our presenters once more. Thank you so much, doctors, for your presentations. I was just feeling sorry when I was listening to Dr. Jocelyn. Some friends of mine who love pork so much, and I was wondering. It sounded like a death sentence, but I hope you'll tell us also how to, some of us who have misbehaved, how can we clean our arteries? There are too much movement, color inside, which may not be good. But thank you so much. It's been highly informative. Thank you. Now we're going to have 3 questions at a go, so that we don't have too many at once. And then I'm thinking that if you feel you want extended consultations, these doctors are available. This was the free session. You may have to provide your Visa card for the extended consultation, which is good value, because my view is that it is safer and cheaper to spend the money on consultation now than when you have the headache that Dr. Luzige talked about. And he's being very kind, because it can be much more than the headache. Thank you. So we'll take the first question. The last people to come in are asking first.
Vanangi. Thank you very much. Thank you, doctors. Your name, please? Yes, Rebecca Mcha is my name. 2 questions, Dr. Watja. You talked about the prostate cancer being hereditary, but one thing I wanted to know, is it cancer is cancer? Because if it is hereditary, must they suffer from prostate? Oh, because why I'm asking this, there's a family I know, actually, where I marry. Yes, 2 elderly people have died of prostate. Their sisters, one has died of breast cancer. The another one died of another cancer. There is another one who has colon cancer. So now, is it that, because you said that if it is prostate, then it is prostate, then they will suffer from prostate. Maybe I didn't get it well. Thank you very much. Then another one, you talked of the screening. Why don't you advise, when I go for screening, instead of doing these small ones, I do straight away to MRI, so that they test me and they know what is happening. Thank you very much.
Thank you, Rebecca. Ladit.
Thank you very much. Mine goes to Dr. Wetia. In the initial stage of your presentation, you asked several questions, but I think some of the answers didn't come in the presentation. For example, the issue of herbal medicine in the control and prevention of prostate cancer. And the second one is the issue of sex in respect to prostate cancer. If you could throw some more light. More would be better.
Okay. The last of the 3 first questions.
Thank you very much, moderator, Dr. Mbonyi and the team. My question goes to Jocelyn, Dr. Jocelyn. There is a chart. Is it in Essential 8 or something? Essential 8 or 80? How can we get that? Is it possible to access that chart? Thank you.
Thank you very much. We'll get the responses. Start with Dr. Wacha.
Thank you very much. Do I remain seated? Okay, thank you. Thank you very much, Rebecca Mujisha, for the questions. Many cancers, okay, may have a genetic component. So when we talk about family background, it does not mean that all the cancers are family. There are those that have a familial tendency, and there are those that don't have. And in the case of prostate cancer, there is a lot of work now going on to try to track those unique genetic components that are responsible for cancer of the prostate. There is a very renowned gene now, the BRCA or the BRCA gene, which is well known for causing breast cancer, and now it is also known for causing prostate cancer, and also in colon cancer. It's the same gene, but it is all over the place. So there are multiple genes that are associated with prostate cancer. And much of the work now is being done in Africans to see why Africans are getting this disease so frequently. And there are a number of unique genes that have been found actually in Africans, unique to Africans, that are responsible for the cancers. But it is true that sometimes you find a family where you have 4 people who have had actually very aggressive disease. I have looked after a family where all 5 have had aggressive disease, except one who came early to me and had a cure, who has sailed through. But his disease was aggressive, but he was fortunate to have a cure. But all the others, the disease has been aggressive. It has killed off 2 so far. One is still battling with the disease, and one has been lucky that he's now 10 years okay, because he came early. He saw his brothers going, and he came early. So it is true. It can be. The second one was on, I wrote it down, on screening. Why not go to MRI? The cost of an MRI is 700,000. And it is not a test that is going to tell you that you have cancer definitely or not. It's just a guide. So when we do screening, the idea of screening is to sort out the population, okay? So you have many people, and you want to know, is it possible somebody has a cancer? It's like a thief has stolen on a village, okay? And then you know that the thief comes from the same village, and you are looking at houses. There are those you point out, you say, that one we should enter to check. This other house, leave it alone. So that is how screening works. There are those suspicious ones where you go. Now, when you have entered that house, and there are still many indicators that this could be the house, then you can carry out more tests to find out. You may bring in our sniffer dogs, okay? And you find a thief. So it's teasing out to see how you get the right person, or how you get the person who has the disease. If you did MRIs, it's really expensive, and you may, out of maybe 100 MRIs, you may find in 1 or 2 if you haven't started it the other way. And you have subjected somebody to unnecessary tests. And you know, in medicine we say there is no test or no medicine without a consequence. We don't know. We may say MRI is safe, but maybe you never know what we find in the future. So it's not worth taking that direction. And then about the questions, yes, I was actually waiting for this moment to see how many people have think they have answered these things in the right way. Okay, you are right. Herbal medications didn't feature so much in my talk, but there is a lot of talk about herbal medication and prostate cancer. People are swallowing to prevent, okay? But there is no evidence about that. There is no evidence that that herbal medicine will take. I think there is the commonest, the sour soap. But there is also another one, yeah, all those. There's no evidence that they prevent. There was a very big study which was done actually, but this was in Europe and the US. They tracked very many people to see how these things control prostate cancer, including tomatoes and all the like. They did come up with a real link. But there is also another herbal tree. I've forgotten the name. Africana, Prunus africana. Yeah, there is no evidence that it will protect. There is no proper evidence to guide that it may protect. And I've seen so many patients who have been taking it, and they come, eventually they confess, this is what I've been on, but still they have the cancer. So it's not preventive, neither is it a cure. And then sex, that too much sex will cause prostate cancer. That's a very common belief, but there's no scientific explanation to it or scientific basis that too much sex will cause cancer or will prevent from cancer. There are two beliefs. Others believe that too much sex will prevent cancer. Others believe that no sex will cause cancer. So there is no scientific evidence. The doctors follow the science. so the science. But let me take this opportunity also to talk something Dr. Jocelyn mentioned, because it had nothing to do with the cancer. Dr. Jocelyn, about the clogging of the vessels, because you said it is one disease. We the urologists actually feed you a number of patients. You know that? Because the penis vessels are very tiny and they clog faster than those of the heart. So one of the warnings that things are not going to go well with the heart in the future is the erectile dysfunction. And we really feed you with a good number of patients.
Just to add on the clogging of blood vessels. Clogging of the blood vessels of the heart and clogging of the blood vessels of the legs. You didn't tell us whether there is something that we can do about that.
Okay, thank you very much. Dr. Ben, Dr. Watia. So first, Dr. Watia is very correct. That is another huge problem. You know, people come and they're like, okay, erectile dysfunction has become a big problem. And, you know, everyone wants a magic pill, okay? Like, give me a tablet, solve it. But it goes back to that process many times, okay? So what can we do about the clogging? So the first thing is to prevent it. Okay, prevent it if you can. And as we said, we had that slide showing the modifiable factors, things that we can have control over. We agree sometimes we don't have full control. So meaning, let's control our blood pressure, meaning first check it. If it's high, if you're advised to treat it, get it treated. Check your blood sugar. If it is high, get it treated, okay? And of course, also followed up. That is another key thing. Many times people start, but then the follow-up is a problem. The cholesterol, okay? Cholesterol is a very big problem. And people, it's very important to get expert advice. Many people come and they say, oh, I went to the clinic, they checked the cholesterol, they told me my cholesterol is okay. just to tell you there are different types of cholesterol. Some cholesterol is problematic for being high, and another type of cholesterol is problematic when it is low. So when you just go to the lab and they tell you, oh, your cholesterol is, people will often ignore the low one and they'll be like, oh, it's not high. So it's very important that it is checked. Then if it is high, does it need treatment in terms of medicine, or can lifestyle modification be sufficient? So that is when a doctor will give you advice, or they'll ask you to meet with a nutritionist to say, do ABC, okay? But there are things like, so we just go back to that last chart, which we'll have. I'm happy to give the slides to Dr. Ben to share with you, or just that chart. Almost most of the things that we can have impact on, or that are within our control, most of them are covered on that. It's been shown that people's cholesterol may not be high, but just having very poor sleep patterns, those people can still end up, clogging the vessels. As I said, that plaque which you see, it's not, although it looks yellow, and so the easy thing to remember is, cholesterol, because we know, cholesterol typically yellow things from cheese to, Blue Band and everything. But there are many other factors at play. Just, being chronically stressed, having very bad sleep patterns will cause, there's a word we call inflammation. It's actually an English word, but we use it a lot in science. Like your body is irritable, it's not quiet, it's not settled. So even inside the blood vessels, there's a test we can do, okay, to measure that. So when someone comes and I'm really suspicious, I'll go beyond just the cholesterol, blood sugar, etc. There's something called high sensitivity CRP. It measures someone's level of inflammation, that chronic inflammation. And that is why some patients have come and they say, they gave me this tablet, but my cholesterol is not high. Okay, so sometimes we can use some tablets just because we can see that your level of inflammation. So when those blood vessels, it's like they are irritated inside, it means that even when that plaque is very little, it's 10%, it is likely to crack. And then you'll form a clot which will block off the 90% lumen. Okay? So those are things. So, having good sleep, avoiding stress. When we talk about eating, even just eating a lot of carbohydrate, even if you're not overweight, okay, but you're eating a lot of carbohydrate, it is actually pro-inflammatory. Whereas fruits and vegetables, they're like, they release things that will reduce the level of inflammation. Many people will have heard about nitric oxide. I'm using these words because people are now reading a lot. From the prostate supplements, we come to Cardiozoom, which I'm sure has reached everyone's phone. And I know Cardiozoom is talking about it releases nitric oxide and all that. That is okay if it does it, but the thing is that we don't have sufficient evidence, okay? But fruits and vegetables will help you to release a lot of nitric oxide, which helps your blood vessels to relax and be open, and it reduces that inflammation within the vessels. So that's why I was saying it's not as straightforward as, how much plaque do you have? You may not have a lot of plaque, but it may be very unstable, very irritable. So it goes back, if you can do that chart, I feel like that is the minimum level of things that each one of us can be able to do, and it can reduce our risk of running into events by over 50%. Like, we don't have to make it very complicated. Thank you.
No, there is a question I asked, and when the blood vessels in the heart are blocked, or legs, do we simply wait for them to be cut off? Heart attack or what?
Okay. Thank you. So, if the way we showed, if someone comes and they're like, they've not run into a full heart attack, okay? Or the blood vessel in the legs is not totally blocked, but they say, when I walk, I feel pain, I feel this. Then we can check, okay? And this test is called an angiogram. So basically, you can be able to go to theater. It's a theater, although it's not for opening the chest. It's called a cath lab, okay? And by without opening that, so we go through a blood vessel, either right here or in the brain, we can be able to advance a little wire into the heart. So you flash a certain dye, and you can see that this is where the blockage is, and it is at 80%, it's at 90%, and we are able to open it up, okay? You know, you advance, it's like a mesh, circular, it's called a stent. And then you advance it up to that point. Of course, as you advance it, it is collapsed. Once you reach that point, you blow in air or something to expand it. And then, you know, it pushes that plaque. That plaque is, you know, it pushes it against the wall. And then that blood vessel can be restored to its full patency. 100% or 80%, whatever you can achieve within the circumstances, okay? However, that stent is not the end of the story, because you need to look after it. It's a metal, so if you need to remain on some medicine, if you don't take that medicine, any metal in our body will not can form a blood clot, okay? So, but that is one of the things that can be done either electively, meaning this person has come in complaining but they are stable, or even when it is a full-blown heart attack, if someone comes in within time, you know, at least within 12 hours. If someone comes and says, this chest pain started 3 days ago, many times by that time it's a bit late. The same can be done for blockages in the legs, okay? And now today, the same can be done even for strokes, if someone can be able to make it to the hospital within 3 hours, within 4 hours, and now it's being extended even to within 12 hours, okay? This blood vessel can be opened so that someone doesn't have to walk around forever with a leg and an arm that are weak. The other option, sometimes you find that blockage, but it's just not amenable to being opened. Okay, like when that plaque stays for very long, it ceases to be soft. It has like calcium in it. It's very hard. So you try to expand your stent and it can't. Then I'm sure you've heard about people getting bypass surgery. Okay? Bypass surgery is like bypassing it. If I said here is blocked and we can't open it, we just have to find an alternative route, okay? But that requires opening the chest, and a blood vessel is taken either from your leg or from your arm, and you start from where it's open, bypass the blockage, and connect distally. Thank you.
Thanks very much indeed. What about the patients who Dr. Watia refers to you? Do you bypass? Do you put in stents? Maybe this is for Dr. Watia.
Yeah, it's quite unfortunate because vascular surgery attempts have not been very successful for the penis. But medications help, but also knowing the problem that is causing the problem is the advice to stop the process going on, and then also sending to the cardiologist, because usually it is a warning that in the next 6 months or a year, the heart may be a challenge. So as they come and we detect that, we refer, we give them medication, but we also advise on exercise, diet, and all the like. But I also want to extend a question to Jocelyn. You mentioned about sugar. People look for alternatives for sugar. They don't give up sugar. You should tell us about those sugars, the honeys, the what.
Actually, I had wanted to ask a question to Dr. Jocelyn and Dr. Simon about the different conditions you gave us and lifestyle problems. Do we have a list of what we should eat and what we should not eat? And also a list of what we should drink and what we should not drink? Well, how much you have to close the bars?
Yeah, thank you, Dr. Ben. So thank you so much for, it's true, among the issues Dr. Jocelyn was referring to as modifiable conditions, diet is a very big factor to that. And this diet cuts across things like sugar and substitutes. The sugar substitutes that we have, for example, stevia, I think that one, unless my colleagues can comment, that one I think has been a better alternative. Even honey, interestingly, the challenge normally is the quantity. There are people who have what they call a sweet tooth. Stevia can help such a person because stevia doesn't have any glucose, so you can sweeten as much. But as much as you put too much stevia, you notice that the taste of that drink becomes also funny. So there are those options. They are definitely better than the sugar that we normally refer to, including corn sugar that the Americans use to sweeten their Coca-Cola and sodas. Whereas we use sugarcane sugar in Uganda, but I think in the Coca-Cola in America, they use corn sugar. Yes, sugar from corn, maize. I don't know how they do it, but there is science for that. So then you come to, of course, the famous, what Dr. Ben is referring to, the bars, the alcohol. Alcohol is a very complicated subject. But what we all appreciate that alcohol is a function of quantity. They are recommended daily quantities of alcohol recommended in terms of intake. The problem is that it's very difficult for people to stick. The way we've found it very hard to stick to traffic rules in Uganda. It's possible, but it's very difficult and requires a lot of control, internal controls and support mechanism, family, friends, besides the policy. So, but there is, alcohol per se is not totally a bad thing if kept within. If you can avoid it, the better. Hallelujah. Alcohol, tobacco smoking, sugar, if you can avoid it, that's better than trying to do what we call risk modification. It's like people have been found not to be able to stop drinking alcohol. So we talk about risk modification. And that's why the allowable quantities of wines and the whiskeys and beers are well prescribed. Even our own WHO, the World Health Organization, recommends certain quantities. Interestingly, among the, I always make this joke with my patients, among the cholesterol spectrum, they are what we call good cholesterol. And interestingly, Jocelyn, you can challenge me here. The only food commonly referred to that can increase your good cholesterol is alcohol. Is it true? So, but the problem is the quantity. The good cholesterol is called the HDL. So if you look at your spectrum of test results, there's called the LDL and the HDL and the triglycerides. The HDL is a very difficult one because there are not many known foods that can increase it. But what is interesting that people who consume alcohol have a chance of improving. I don't know how. I'm not recommending that you start taking alcohol. Please don't quote me. But it's there in the literature. The issue is the quantity. The list of foods, I think that's why at Nakasero, the issue of the Department of Nutrition is the big one, especially as we talk about health promotion. So we are really trying to push this concept of nutrition and wellness, because that's where we have a gap, an opportunity to prevent this costly diagnostics and treatment that we are offering to patients, and you really see there's not much benefit. So that's, as a principle and policy, we are trying to push. So nutrition and having a nutrition visits. If you look at our wellness packages, a nutritional visit is part of it. And it's very important to discuss about food. In America, for example, when people are going to watch football, going to the family, to the films, they talk about food. Where are we going to eat comes first. So it means food is a very good, nutrition is a very good opportunity for us to actually modify a lot of factors as among the list of the essential life 8 issues. So I think, Dr. Ben, I hope I've tried to answer that question, but the fact is that there, and I think we can share with our nutritionists to, as part of your scheduled annual checks up, it's important you agree on what you are going to eat. And the food the nutrition is going to advise you is going to be rotating around what you are able to eat, culturally and traditionally. We are not going to ask you to eat broccoli when you have never seen broccoli. But we might advise you to eat fene, avocado, the food that are available. For me, I come from Kasanda district, a sub-county called Bukuya. Broccoli is strange. But we have something called a chisusuti. Yes, it's there. Suit, you grow one piece like this, can bring a tree down by the weight. So those are the things we discuss with the patients. So, I think those are my comments. I hope I've tried. I just want Dr. Jocelyn at one point talk about the issue of aspirin and clopidogrel. And then also Dr. Wacha to tell us about the issue of when is the right time to do a PSA. Because the people walk in random and they do a PSA and then they find it increased by 0.2 and then they start crying. When do we recommend patients? I understand it's a ceremony. You just don't walk in and do a PSA. You may not do a PSA after certain activities. Dr. Watia knows those activities better than me. Thank you.
Okay, thank you, Dr. Simon. Just to talk about the aspirin and clopidogrel. So basically they fall in, most people know aspirin, okay? People call it junior aspirin, aspirin for the heart. Yeah, okay. This is Exosuti. Okay.
Understand?
Okay. Okay, thank you very much for that. I've been seeing it on the roadside, but I've never bought it. I don't know what it's called. To Dr. Simon's issue of aspirin and clopidogrel, I know most of us know aspirin, okay? But clopidogrel is, its counterpart. They both are what we call them antiplatelets. As we've said, for most events, whether strokes or heart attacks, there is a narrowing that has been there, but what really bangs in the nail is forming a clot, okay, which then blocks off that little remaining lumen that was taking blood. So you want, and for you to form a blood clot, one of the major cells we use in our body are called platelets, okay? They're one of the components that help to form a blood clot. So meaning that those platelets, yes, we need them. They are good for when we injure ourselves, because people who have platelet problems will bleed and bleed and bleed without stopping. But then also for when you don't need a clot, you want to disable those platelets. You don't want them to be, meeting up and then blocking off your little remaining space. So for many years, it was known, as I did my medical school, it was known like everyone over 60, diabetes, high blood pressure, be on aspirin, okay? At that time, clopidogrel wasn't there. It is, more recent, like from the past maybe 15 years. So everyone would be, I take aspirin, I take aspirin, I take aspirin. Lately, that has changed a bit. Okay, so we no longer just give it out. So we used to use it for what we call primary prevention. Primary prevention meaning you're preventing a problem before it has happened. Secondary prevention means this person has got a heart attack, but you don't want them to get another one. So there we would call it secondary prevention. Primary prevention means, you're likely at risk of a heart attack, let's prevent it from happening, but it hasn't happened at all. So for a long time, it was used a lot for primary prevention, but in the recent years, the evidence for that has actually changed. It has been shown that, the benefit for primary prevention, especially people whose risk is not so high. So who are the people who are at a high risk? And sometimes when you come to my consultation room, I can be able to calculate your actual risk of getting these events in the next 5 years, in the next 10 years. We are using the word risk. It's not a prophecy. We are not saying it must happen, okay? But we factor in things like what's your age, what's your weight, what's your cholesterol, what's your blood sugar. For example, by and large, people who have diabetes, their risk is much higher compared to people who do not have diabetes. So now we know that by and large we use those agents, aspirin, clopidogrel, mostly for secondary prevention, and for primary prevention it is in selected individuals based on the risk. It's no longer a one-size-fits-all. We don't just dish it out, because actually research has shown that it's probably doing more harm by being dished out to everyone, even people whose risk is low. Risk of bleeding, risk of several things, okay? So it's no longer given out to everyone. So if you're taking it, you need to cross-check. But for people who have already had events, it's very important, and actually aspirin saves a lot. For people who will know, like, you know, this pain, from what I've had, what I've read, it sounds like it may be a stroke, it may be a heart attack, or symptoms of a stroke. You know, someone can take an aspirin before they leave their home, and it may really save their life. So those agents are very important, but you need to be knowledgeable because they also come with their challenges. Anything else, Dr. Luzige?
Thank you very much. I will probably ask the first question, and then we'll take two more. Dr. Luzige, my question is about lung cancer. I recently heard something on the BBC, one of those stories that they ran, and the way that they were putting it was that lung cancer is almost at epidemic levels in the UK, to the extent that they have free vans going around in communities doing tests, free testing. So for me the question is, what is your take about the prevalence of lung cancer in our country? Myself, I'm predisposed to allergy, you know, and I find that my children also have very similar symptoms. It may not be to do with lung cancer, but is there something genetic to do with that, or is it an environmental kind of issue? And then, Dr. Watia, the question is, in cases where you find someone has done PSA tests that don't seem to show the existence of prostate cancer, what would explain the symptoms that you talked about, frequent bathroom checks and so on? Is that something you could comment on? Let's get two other people to ask.
Thank you, Paul. I will start with Watia also. Dr. Watia, thank you for your presentation. My first question is related to Paul's. I know of a patient who had a normal PSA, very normal PSA. But 6 months later, after that PSA test, this person was found to have tumors all over of prostate cancer. Now, what is the prevalence of such cases? You have normal PSA, but cancer has already spread. And how do we avoid such a risk to that? PSA alone is not adequate to tell whether or not you have the disease. The second question is for Jocelyn. We hear these days that there are quite a number of cases of clots. I have no evidence, but you hear clot. Somebody has died, collapsed. And people are linking it to the COVID vaccine. Is it just, you know, hearsay? What is happening and how can we prevent that? Secondly, we have talked about alcohol. There is a notion that a glass of red wine will keep you from heart problems. Let's be specific. Is that true? Yes, we're in church here, but is there any science to say a glass of red wine is good for your heart? Then lastly, Dr. Luzige, you talked about, you said previously there was no cure for diabetes, but I heard you say that you now know that diabetes can be cured. Can you shed more light on that? Thank you.
Thank you very much, Dr. Sam. Did they say a glass of Omuramba as well?
Thank you, Paul, and thank you, our doctors. I have two quick ones. Sorry if it takes you back. On the erectile dysfunctionality, there is the issue of the psychological disorder or effect. When you do a test, do you go that deep to know that it is actually psychologically driven? Two, on nutrition, we have so many mushrooming I would say, places where they call, they invite you, come test your blood, and then will tell you what you should eat and what you should not eat. And we have had cases where, because of the kind of too much restriction, they have been misled to the extent of losing some of the necessary nutrients in the system. And it becomes a problem actually to rectify that if they were better advised. What do we, as medical doctors, what can we do? This is public health now, to discourage that kind of stuff. Or are they genuine anyway?
Thank you. Let's get responses and then we'll take the next round of questions.
Thank you very much. Dr. Rizige, you asked something about ceremony of PSA. Yeah, it's not so much, but what we know is that sexual ejaculation temporarily increases PSA, but that lasts about 48 hours. Yeah, and infection. So, unlike prostate, yeah, urinary tract infection. That, as long as the urine is infected, the PSA will go up. So the ceremony is just, the key one is knowing that it's not good to go for a test after 48 hours after ejaculation. So it's better to keep away. The rise is not so much, it's temporary. Then there were other questions of somebody who had a high PSA. Hello? With a normal PSA. So PSA is a good, what would we call it? A tumor marker, but it is not so it's not specific, but it is a better evil than all the other tests. So it can pick up many patients. There are a few incidences where you have a low PSA and cancer is very active. And we have had such patients. But that is why it is good to combine PSA with assessment, a doctor's assessment. Because I have got one patient recently, okay, who had actually a high-grade disease. What we call high-grade is the one which has the potential of spreading very fast, who had a below normal PSA, or what people regard as normal, because under normal circumstances, they will tell you that from 4 and above, that is likely to be cancer. Now, his PSA was 1.5. But the only thing was the examination. The examination told me that there was something suspicious on his prostate. And indeed, after doing the biopsy, the disease was there. And indeed, even when we did all the PET scans and everything, the disease was there. And he had to go for a curative surgery. So really, PSA is so good, but it's like HIV test. Did you know that? That you can have an HIV test when you have the disease, and it says negative? Or did you know that it can say it is positive? But the incidences are small. That's why we talk about sensitivity and specificity of a test. So we may not rely on only one thing. So we incorporate something else. Even for HIV tests, if there is any reason there is discrepancy, they put in another test. Okay? And then we have a tiebreaker. And then we go for a more confirmatory test. So the tests are good, but there may be a small percentage where there could be a false negative, even a false positive.
Let me supplement what Dr. Watia has said. Imaging facilities or laboratory facilities are simply supportive facilities to the doctor. The first thing is taking a history and examination, thorough examination. Then it raises your suspicions. And it is those suspicions that now lead you to what you should ask for in the laboratory or for imaging. Laboratory and imaging cannot be the first line of treatment for somebody who suspects he's got a disease. The protocol is history taking, examination, then you carry out the others as simply confirmatory services. That's the procedure. But what we're talking about the screening is when you have no symptoms, no complaint of any kind, and you are simply carrying out certain tests to see whether they can bring out something that may be silent. But if you come suspecting that you have got any disease at all, any kind of disease, we take a history, we examine you, and then we use those other imaging and laboratory services to confirm what we already suspect. We don't rush straight to MRI, somebody who said an MRI to diagnose everything. There are certain conditions which an MRI will not tell you. It is also specific on what it can find out. So it's not conclusive that it will make sure it will find out that you have got certain diseases, for instance. It may not find out that you have an HIV or that you have diabetes. MRI will not tell you that. Yeah. Urology.
Okay, thank you very much. I think I'll share most of the questions with Dr. Luzige. But in line with what Dr. Ben has just explained, I just want to really caution us or just encourage us to use the right procedures. It's becoming very increasingly common, like now that people know PSA, and there are these mushrooming clinics everywhere, okay? You just walk there, do my PSA, and it's normal or it's not. Let me tell you, for us, at least in my practice, even with all the fancy equipment and what, we still make almost up to 70% of the diagnosis from listening to the history from a good physical examination, which you may not be able to do if you're not a trained medical person. So there are not many tests in medical practice which will tell you you have it or you don't have it. There are not so many, by the way, not even the malaria tests that we do every day. Okay? So it's very important. If you want to do that, just schedule an appointment, go and see. And you don't have to be seeing the consultant every time, okay? Some of these are programs by Ministry of Health where we know screening can be done at a health center for. So there are programs. Some screenings can be done by nurses, some screenings can be done, okay? There are mobile, activities if you're lucky. So it's important to know the systems that are in place, but get a professional person to be able to help you to interpret things. So it's not a matter of I'm doing that test. I just want to talk about the HDL and alcohol. So yes, alcohol is proven to raise the HDL levels, but it's also proven that that increase in the number does not offer cardiovascular protection. That is, the literature is very clear on that. So the number goes up, but actually, following up that group of people versus those who are not taking alcohol, their risk of cardiovascular diseases is not different. Okay, so if, just to clarify, I know people often ask about it in a joking manner, but, it's okay if you decide to the alcohol, take it within the recommended amounts, but you shouldn't have any false expectations. So you know why are you taking it, what's the amount, and what are you achieving with it. Blood clots. I want to briefly talk about blood clots in general, but the relation to COVID vaccines, I'll ask Dr. Luzige because that is his area. So blood clots, when we saw most of this clogging, not most, all of this clogging that we talked about is on the arterial side. So we have call it two sides of our blood system. We have the system which is taking blood away from the heart to supply, okay, the organs. Then we have that which is getting from the organs, taking back to the heart and to the lungs. So this clogging that we saw is in the arteries which are taking blood away from the heart. Then we have those which are taking back to the heart, which are called the veins. So, starting from the legs, that's where the clots most often start. Not always, they can form elsewhere. And then they end up in the lungs. That is when you hear someone, another person has just died in the office, like that. So these risk factors, the traditional ones we talked about, are for the arteries, the clogging. But again, things like obesity, things like smoking, they also form major risk factors for the blood clots on the other side of the veins, which end up in the lungs, and also someone can just, collapse in 1 minute, like that. The linkage to vaccines, of course, is proven, but I'll ask Dr. Luzige.
Thank you so much. Yeah, let me start from that point. Yes, there is a very, very strong linkage between the incidence of clots in the veins, especially, that lead to clots that move away from the legs to the heart, to the lungs and the heart. So that is there, and that's why there's been a very big review of the vaccines and the science and around vaccines to improve and reduce that risk. Of course, at that point, you remember, is it the vaccine or is it the thing itself that they're using to make the vaccine? Remember, even patients of COVID themselves, probably 80% of them died because of clots. Yes. That's why some of them would test you, the test is negative, but we say you are dying of COVID. COVID was here, caused its havoc, went away. Now that havoc, it lives. One of the havoc is changing the blood vessels to make them become clotty. So COVID patients actually died a lot because of clots, pulmonary embolism. That's why most patients with COVID, if you remember, were on blood thinners. If you remember, 2021, 2022, every patient with COVID was on blood thinners, if you remember that. So there seems to be something around that issue, the antigen of the virus or the antigen in the vaccine process. So there seems to be something there. And for the vaccine, yes. And specific types of vaccines. That's why in some countries, some vaccine types were banned, were no longer used, are not recommended. So yes, there is. And that's the price we paid at that time. Of course, we hope that now with the review process, we might learn and understand it better. But yes, there is some sizable concerning correlation between vaccine, people who received vaccines, and not everywhere, in certain populations. But if you look at the risk at that time, the risk of dying from COVID was far higher than the clot. We could do something. And that's why we took that route. It was a very difficult one, but one would argue that it was probably a worthwhile price to pay. But that's the science, and that's the science we live in. And that's why we don't prescribe drugs to everybody, because the same drug I'm giving you to treat this may cause this problem. So regarding the issue of diabetes cure, so again, I don't want you to because of transparency, we have to tell patients everything. It's true there are some patients who may get off drugs and diabetes becomes quote-unquote cured, especially if you modify this thing that we can modify, diet and lifestyle, exercise. Not every diabetic patient needs to be on medicine. Maybe let me simply put it that way. Your medicine may actually be your diet, which the former Director General, Professor Maswa, said that medicine starts from home. Food that we eat has a very big impact on your glucose metabolism and even hypertension. So, in that spirit, what I'm trying to say that it's possible that you can be off drugs, some patients. But please don't say, my neighbor, therefore even me, let me try that route. That is a conversation we need to have, and that's why we visit doctors on scheduled visits, and we try to approach medicine from individualized medicine. There is no one shoe fits all issue in medicine in the way we look at it at our level, at least professionally. We have to tailor medicine for each patient. And if you do that way, you realize that some patients do not need medication. But give us an opportunity to find that through our routine dialogue. Don't quote your neighbor and say, let me try my neighbor's diet. You are different, biologically different. And that's the beauty about the genes. Allergies. Allergies is a function of inheritance. There's a lot of inheritance when it comes to allergy. Allergy basically is the body's immunity being oversensitive. It's like when you have a very nice dog, but it's barking at even wind. When you turn in your bed, it barks because it has had a noise. So the body is too sensitive. All of us want to have a very good immunity. But when the immunity is too sensitive, it becomes an abnormality. You cannot sleep. So we have to breathe in air. But some people, the body picks out the nitty-gritty to the extent that it becomes a disorder. And that seems to be inherited, that sensitivity of the immunity, where people are too sensitive to the particles in air, some of the proteins in the foods we eat. That is something that can be moved from within the family. It tends to run in the family, so it's inherited. It's a disorder because it impacts on quality of life. You cannot be in this room, and for you, you have to wear a mask and stuff because breathing the same air, you are coughing. So, but it's manageable. That's a good thing. It's very manageable. But it also speaks to the changing quality of air around our communities. So, and that goes to the first question you asked about cancer in the lung. The lung, from us, is like the skin. This skin, if I'm not putting on my shirt, it's exposed to the air and dust. The lung, every air you breathe in lands in the lung. So the lung is actually exposed to outside. So the environment in which we live affects the quality of air, and the quality of air, some of the particles have a tendency to cause scars in the lung, and those scars can turn into other things. Of course, there are certain environments. For example, people work in industries. So whereas we are trying to muscle out industrialization as a way of getting out of poverty, but this has to be controlled. You cannot have factories where at night you see smoke going on. We are building our homes within the factory areas. Now that is where we have a challenge. So in 30 years' time, we may be struggling with these issues. You go and just go to Kalolo Summit View and look down. You will see smoke coming. Industrial area, factories. At night, during the day, they are silent. At night, smoke. So this is not okay. I think you can comfortably predict that air quality in Kampala is not okay. And therefore, the risk is going to be high. In my village, gold is a very big issue. In fact, gold has moved from the mountains, refinery, the artisan kind of refinery of gold, to people's homes now. The Ibanja holders, because of quick money, are leasing out land to people who are refining gold. And if you see what they're using, mercury, this is not okay. So you can almost predict that there's going to be a problem in such a community. So smoking, of course, that we all know. Luckily enough, in Uganda, it's very rare. I think the government has done a very good job in terms of controlling smoking. So it's actually unbelievable that to find somebody smoking is not easy unless if you go to the bar and find shisha. But even shisha bars now are very highly regulated. So I think that was a good news, but now the industrialization is where I see a problem. Yeah, thank you. Mental health, I think Dr. Wati at one point can talk about mental health and ED. It's a very big problem. 90% of the time before we give you medicines to control erectile dysfunction, we assess the mental health, the stress and depression and anxiety first.
Well, I think you have answered it.
Thank you for answering, but actually we don't take erectile dysfunction lightly because we go into the depth to find out. The biggest percentage of erectile dysfunction is actually psychological, but it also points to a lot of things. As you have already seen, it points to the heart, and there are other things which in the network comes to erectile dysfunction. So each time somebody comes with erectile dysfunction, people should, I encourage you to stop taking it simple, so that you just go and buy medicine or just take herbs. It is always good to consult. And we link many diseases to erectile, including diabetes, including kidney failure, so many things. So we, including medicine. So we go into the depths until we tease out what is what. It's a big pointer to many things.
Thank you very much. We're going to take, I think, one last round of questions. Because
maybe just the 5 arms which are up, and then we close.
Yes. So we're going to take
Don't
the
add
last
on
round
5.
of questions. Now they are shooting up.
I think there are 5. There are 5.
We have 2 things. One is that in our last round of fundraising for our roofing, we had health walks, which were very, very, very helpful. And this lady here, who is the dietitian from the Nakasero Hospital, helped a lot of us who were eating the wrong foods and so on, and making our health situation even worse. So I don't want us to miss out on going to the health desk outside to speak to the dietitians, to check our, our weight and BMI and those kinds of things. There are some people whose BMI is irredeemable, like me. There are those like Mr. Kagoro who don't need to check that table, So, and then we have a cup of tea. So I think that, as I said, these doctors, we can't sort all of our problems in this session, but we have their contacts. We can still follow up at Nakasero Hospital. So let's take the questions that are available now. We'll start with him.
Okay, thank you so much. It's been a blessing to be in this session. My name is Isaac. I'm a dietitian in training, and from Maud Institute of Health Sciences. I look young, but I have few years to 40, which Dr. Watia was talking about, so I'm not so young in the senior citizens. Now, the first question I have is, by age of maybe 40 to 50, you go for the checkups and you realize you're getting the prostate enlargement, and you would love to avoid the risks of cancer, or even there is a detection of probably cancer development, and then you think of omitting sex and you choose to do away with the cancer, with a prostate. Can you have a complete prostatectomy? And then they remove the whole prostate and you live without a prostate. I have another one just because. Then the other question is about if you're maybe having the leakage of semen, or maybe like you observe there is leakage of prostate fluid. Could that one be a sign of a prostate malfunction? Yeah. Then the other one is about cancer. This one is associated because Africa, we are heading to development, and we are having a lot of technology coming in, and we have probably no way of dealing with the effects of technology. Could that one be a factor that is contributing to the cancer developments, being that you talked about a lot of genetic associations with the cancer development in Africa? Could we having that association with electro radiations that maybe we need to be taught on how to deal with the technology that we are experiencing? When you compare with the other developed countries, probably they have the radiation repellents, and for us we are just using the technology anyhow, fridges and everything in the house, but we don't have the way of dealing with such things around us. Thank you.
Those are questions from the Gen Z community. Oh, Mr.
Thank you. Yes. Thank you so much. Very quick ones. My name's Joel Kaswara, and I'm a retiree. Now, I read on YouTube about exercises with regarding to expansion of prostate. It was being said that those who walk at least a mile a day, the chances of the expansion of the prostate gland could be minimized. And no wonder people who really live in the rural area with very basic resources, it looks like their health tends to be relatively better than people with greater means to meet on their health. The second question is to Dr. Luzige about immunization. And isn't there a fear of over-reliance of immunization? To the immunization to the extent that it could tend to lower down our real immunity. And again, looking at the people who live in the rural area, you really find a whole lot of people who are healthy and in very good shape without the kind of facilities that are open to most of us.
Thank you, sir. I'm told that I've been gender insensitive.
Good afternoon to you all. My name is Jessica, and I would like to say thank you to all the doctors. My question is to Dr. Luzige. I would like you to shed light on autoimmune.
Good afternoon, everybody. I'm Lydia. I would like to thank everyone who is giving us great information. I call upon our head of this to make sure that every church member can get such, because they are missing a lot. My question is about how is cancer related to stress? And then about milk. At a certain age, they say don't take milk. Then others say take milk is good for your bones, especially for us, the ladies. And if we are to take milk, which milk is okay? Processed milk or cow's milk or goat's milk or soya milk? And then they encourage a glass of wine is good for one. And us as Christians, it's looked at in a different way. I would like one to talk about this. Thank you so much.
Thank you, Lydia. For me, I take chicken milk. Okay, I think we'll get responses to the. Oh.
Yeah, thank you so much, doctors, for these excellent pro bono services. We are extremely excited. Now, mine is a little bit different from what others have been asking. And this is that sometimes you don't feel okay. And actually, Mr. Luzige talked about our ladies sometimes pushing us to go and to seek medical advice. But sometimes when you go to the doctors and you're not feeling okay, you're having maybe dizziness, so you don't feel well, weak, and they listen to you, they talk to you. Sometimes they just say, yeah, for you, man, you're just stressed. Now, then you wonder, and that is one aspect. And other times, you go to a doctor, they do tests. That's why I went somewhere, okay, specifically for me. I went and they said the thyroid was so high. And then I said, at least, for me, I was happy that at least I've gotten what is disturbing me. Then I take them to some senior physician like you, and he looks at them and says, these results are rubbish. And he asks me even that, can I throw them in the dustbin? Then I'm puzzled. Then I go back home, totally puzzled, and I tell my wife, don't send me back to the doctors.
Thank you, everybody. My name is Annette. Thank you, doctors. My question is, for me, sometimes it becomes as a stress that when I think about going to bathe, sometimes when I come out from the bathroom, I have that itching body that I can scrub my body sometimes, and it becomes a stress to me when thinking about going to bathe because of water. Thank you.
Thank you, doctors, for the great information. It's quite helpful. Mine is on the diabetes, if it is hereditary. Can it be healed irrespective of whether you have a big body or not. Sorry for the word. Thank you.
Have you got the last question? No, the last question she asked. You got it? Okay. Okay. This is the last question.
Okay, my question goes back to Dr. My name is Joan Kagoro. My question is going back to Dr. Washu. I don't know whether I understood you when you began explaining when prostate cancer, and you gave us symptoms of prostate cancer, and then you also told us the good zone is when you are in 1 and 2, but then when it moves from there, it is in a red zone. And then you also gave us symptoms, for example, frequent passing of urine, the pushing and all that. You gave us 1, 2, 3, up to 4. And then you said that is already a red flag. So how do we know that we run to the doctor now before those symptoms? Because those symptoms are those which are like trigger, which pushes us to go to the doctor. And then the other one was on the heart. And in there, cholesterol from Dr. Roslyn. Cholesterol, of course, Lydia mentioned it, don't take milk, don't take this, and then the cholesterol levels are high, and then others say you take medicine, so how do we control the cholesterol if it's not diet related? And then also the red flag on, you said when we are climbing the stairs, you feel like your chest is paining, and then the next day you avoid and start turning it around and you avoid climbing the stairs because those are symptoms of heart attack. So when do I feel like, of course I will feel the pain, I will feel climbing the stairs, but is that all the symptoms, or when do I run to the doctor? Because I would be frequenting your hospital if all the pains keep coming and I'm coming, or I can go back home and stretch my leg and do all those exercises which I can do, and I don't run to the doctor. Yes.
Thank you very much. Before the responses, I just wanted to give a testimony of, I think, the benefit of exercise. My father is 85, and he's now retired. He used to come to my office to pick his mail from post office. And he would stop at public service or at the Wandegea, the Mlago roundabout, and he would walk to Nakasero, and my office is on the 3rd or 4th floor, so he'd walk up. Now, one time he came and he reached the 2nd floor and he couldn't proceed any further. And that is when we realized that he had a challenge with his what? With his heart, and he subsequently went for, I think they put a stent. So I think if he was not exercising, would probably not have known that it would probably have been a case of sudden death or something like that. So I think exercise, whether in moderation or in whatever form, I think is very helpful. So let's get responses from the doctors. Thank you.
Thank you. There were a number of questions directed to me, but the first one was to do with enlargement and cancer. I think it's one of the questions I asked. I don't know whether you were there from the word go, the one who asked. If you missed, enlargement has nothing to do with the cancer. Okay? Those are two different entities. And then there was the other one, which was about prostatectomy to prevent cancer. One, we talked about removing the enlarged part. It doesn't help. And then the other thing is unnecessary treatment may not help unless there is a specified risk. How would you know you'll ever get the cancer anyway? And on top of that, unlike some other surgeries, prostate what you call total removal goes with some side effects. Yeah, the radical prostatectomy goes with some side effects that are not very desirable. And why would you look for them when you don't know whether you would ever get cancer or not? Okay. And then the other one was exercise and prostate enlargement. Okay. Exercise is very good for everybody. Okay. But there's no study yet to link that if you do the exercise, the prostate will not enlarge. So that should not be a statement. As doctors, we always stick to the science. If there is no science, we shall not give the answers that, yes, it helps. We know that exercise will help you entirely. So exercise, but not particularly aiming at the prostate not enlarging. And that does not stop you checking. And then the other one, which is directly to me, was symptoms of prostate cancer. When should we go to the doctor? Because it is confusing. Now, in my presentation, I told you that early cancer of the prostate shows no symptoms. Okay? And I said, by the time it starts showing many times, it is actually out of hand. It has spread. Therefore, if you want to get the disease in the early stage, which is the desirable stage, all stages can be helped, but the desirable stage is the one where a cure can be offered. Then you don't have to wait for symptoms. You just go and check yourself when you reach the window of checking. And the window of checking is from age 40 upwards. Okay? And more so, 50 and beyond. Okay? So that's when you should go to the doctor to check. If you have the symptoms, doesn't mean it is late. You could still have symptoms and it needs to check. You still need to check. So it is always good to check. And we recommend annual checks from the age of 50. 40, you can go for the initial, so that we can know how you stand initially. Okay? Then we may give you 2 years, 3 years, depending on what we find before and depending on your family history. Thank you.
Dr. Watia, should the regular checkup to exclude prostate cancer include a physical examination by the doctor to carry out a rectal examination?
Thank you, Dr. Ambonye. Just a blood test is not enough. A physical examination is always good. And whatever decisions come after should be guided. There are a lot of these papers in the toilet. I don't know whether you people have seen them. Those people are very courageous who carry those papers. They are not medical people, by the way. They have done it to me in my office. They put even when you don't know.
Okay, I think I'll start with Mrs. Kagwaro. You asked about, so should every pain, lead you to a doctor? Because, you may frequent the hospital. And then people also say, what is wrong with this woman? She's here every week. So I think the first thing to embrace is what all of us have been stressing, particularly Dr. Luzige, the issue of scheduled checks or wellness checks, okay? The good thing is that most of these are processes that develop over time, okay? They won't, if today your cholesterol is normal, in a week it won't just, shoot up to levels that are scary. And that is why when you do your wellness check today, then the doctor whom you consult with will tell you, based on this assessment, let's do this again. After 1 year, you may not have to do all the tests at the same intervals, based on the current results and your risks. So they may say, for sugar, let's repeat it after this time. For cholesterol, but several times we tend to, like bundle things up to make it easier for you. Because if I say, do this after six months, do this after 1 year, it becomes not easier. But by and large, that should be the first step. Honestly, if you go today and you do your wellness check and they tell you your risk of having a heart attack is low, your risk of having this is low, you don't need medicine, it is pretty unlikely. You realize all of us as we talk, we are using words of risks, we are using of, what are the chances, okay? It's possible for someone to be given a clean bill of a PSA today, and in 6 months it is CA, which is actually disseminated everywhere. Those cases are there, but they are not very common. And for us, we say that common things occur commonly, okay? So if this wellness check commonly will tell you things are generally okay, and tomorrow you feel some pain, you're likely going to be the person who can be like, maybe let me wait this out, but also it's important to know that the different diseases or conditions, and when we say, what are the typical features of a heart attack, okay? We all get pains here and there. You can get a piercing pain. Most people who will come with chest pain, it will be like piercing. And they say, doctor, I feel it sharp here. That is very unlikely. So when you listen, and as Dr. Ben said, we may not be able to cover everything today, okay? But once you make that consultation, they can tell you typically how a heart attack would present, how will that pain feel, okay? Of course, they'll also tell you whether you're the person, because we have those classes which are likely to be atypical, especially women, advanced age, people with diabetes. They may get a heart attack when they are not feeling any pain, or their pain is very different from the usual, from what is often expected. So to answer your question, we are not saying be at the doctor's door every week or what, but the starting point are those scheduled wellness checks. Then you carry through with that conversation. When you do that check today, what plan did you make with your doctor? When are you supposed to go back, okay? But for someone who is not doing any wellness check, we develop those like adaptive mechanisms, okay? I will avoid the stairs, as I told you, then I can go like that for a full year. When now on level ground, I'm very okay, and I will go for another full year. Then it's until when now also walking on level ground becomes a problem, that's when now someone says, I need to go to the doctor, okay? The issue of cholesterol, it made rounds in even doctors' conferences about 2-3 years ago, okay? When this new science came on the stage to say, by the way, our diet is responsible for maybe up to 30% of our cholesterol levels, okay? And so it made huge rounds, and people are like, okay, so then why are you bothering us? Let's eat whatever we want, okay? But then also you realize like 30% is a big component. So if you're eating carelessly, like all the cholesterol-rich foods, that will actually shoot up the cholesterol levels. But the truth is that a significant percentage, and probably more than 50% of our cholesterol levels is genetically controlled, and that doesn't depend so much on what you've eaten. That's why we have some people where we call it familial hypercholesterolemia. You find someone very thin, and this family, they are very thin, but their cholesterols are going through the roof, okay? So those, the genetics have a big role to play in the levels of cholesterol. The cholesterol is synthesized by the liver, and so the common medicine that we use, we call them statins. You have had atorvastatin, rosuvastatin, all those drugs. They block that pathway where the liver is making the cholesterol. But that doesn't mean that we ignore the diet. It also has a significant percentage that is controlling. The other big thing that, or can I call it a deception, or something that's not understood, people tend to think that your body weight is going to be related to your cholesterol. Those are two different types of fats, okay? So being big or fat on the outside, which is the obesity, is a different type of fat, which is not good, but you can also be very thin, but your cholesterol levels, that is the circulating cholesterol in blood, can be very high. So there are two different types of cholesterol, but both of them are not good, and they both need to be addressed.
So there's the internal obesity and external
Okay, then it's not internal obesity, but if you want to call it like that, okay? So this other fat is this fat deposited under your skin, okay? And also the other key thing to remember, someone overall may not be very big, but the fat around the belly. Okay, the beer belly. So that is why when I was talking about the BMI, the body mass index, I said that is a simplistic way of putting it. Your body mass index may be normal, but there are other things we look at, especially if you get a one-on-one consultation, what we call your waist circumference. So that fat, which is around your liver, around your intestines, okay, it is one major way how we get to be highly inflamed. Remember we talked about that irritation inside the blood vessels. That fat around the belly is very highly pro-inflammatory. So overall the size may not be big, but that tummy, that fat around those organs.
Thank you so much. Allow me in a minute or two to discuss a few concerns. Vaccines, over-reliance on vaccines affecting our immunity or internal body capacity. Remember I told you that we target. We actually rely on the body. Even these vaccines in themselves do not do the thing. They actually help the body, they like tickle the body to produce more. So it's actually not the vaccines doing the job. That's why some patients who have certain conditions, the vaccines will want to work. When we give you a vaccine, we actually giving you molecules to deceive the body that there is an attack here, so that the body produces. So that these soldiers are there in the event you get. So this vaccination is targeted, and it's not for everybody because some patients do not benefit from it. So I encourage you to get the vaccines. It's really, really one intervention that has made this world different. When I was a medical student in Mulago, we had the ward for measles. Right now, if there is a measles diagnosis, I will also run there to see. There are some doctors who have trained now, the Gen Z, who have never seen a measles case, thanks to vaccination. So vaccines do work. And please encourage people in your communities to vaccinate. Polio. So, and now, autoimmune conditions. This is a very interesting subject. Autoimmune, I talked about hypersensitivity, the body being sensitive. That is the immunity of your body being too noisy. But it's doing nothing apart from the discomfort. You can't sit in the cold, you can't sit on AC, you can't do what. Autoimmunity, the body's immunity is not only too noisy, but now begins to attack you. It's like having a rebellious army. You build your army. If I'm to use the president's word, there's a word you know likes. The development of the army has been professionalize the army. You professionalize the army, you equip it, educate it, and then it turns against you. So, autoimmunity is something similar to that. What triggers that autoimmunity up to date remains an enigma in the medical world. We have ideas of what can trigger it because we know certain foods, certain medicines may trigger, certain infections can it trigger. For example, COVID. COVID has been known to trigger autoimmunity. There are certain autoimmune conditions that have increased just after the COVID epidemic. So autoimmunity are conditions whereby the body attacks its own self. And these tissues can range from blood vessels, brain tissue, kidneys, the eyes, the skin. Interestingly, what we can say now, there seems to be a hormonal preponderance to these things. No wonder some autoimmune conditions are predominantly common in women. And you'll never find them in men. Others, they are common in both men and women, but women take up the big chunk. Some of the common that you'll hear in the community are, for example, rheumatoid arthritis. There are two types of arthritis you commonly hear. There's one called osteoarthritis, which is due to degeneration, but there's also one called rheumatoid arthritis. That's an autoimmune condition, can attack you at any age, but more commonly in your 40s. And most commonly, probably 7 out of 10 are ladies. And then there's a condition called SLE, systemic lupus erythematosus, and then one called scleroderma. These are all autoimmune conditions. They attack the body. What triggers it, we don't know, but we know they are there, and we are at least able to screen for. We can test them, and it's very important that when you get an abnormal rash that you don't know, don't just rubbish it. When you have joint pains, don't assume it's weight. And I'm sure if you went and saw Dr. Ben and you have multiple joint pains, he's not going to assume because you are 50 or because your weight is high. He will definitely send you to some lab tests. And one of the things he's probably looking out is to exclude or rule out those autoimmune conditions that commonly present with joint pains. So autoimmune conditions are common, and these are some of the complex conditions I was talking about, privilege to doctors, especially internal medicine physicians. Milk is very important. Why? Because it's the common source of calcium. So whereas we talk to you about restricting milk, we are also specific. For example, we'll tell you about skimmed milk. If we are to tell you get off milk completely, most likely the next word will be, can you supplement with calcium? So there is a reason why God gave us these foods. Even the salt that we normally tell you don't eat. Right now, probably there's a patient in the hospital ward admitted because we are trying to put back salt. Low sodium. So it's a balance. And these things require a lot of follow-up discussion with the doctor. So it's very important, these wellness checks and regular follow-up with the doctor. This is where we find these things, and this is where we have an opportunity to impact our knowledge and our experience we have. Last but not least, mental health. It's true, mental health issues, and specifically things like anxiety, mild depression, account probably for about 30% of people's visits. For out of 10 patients I see in a month, for example, probably 3 or 4 of them are just issues of anxiety and depression. And it's normal to be anxious. The problem is if it becomes your modus operandi. It becomes a disorder. And it needs to be managed because it will disorganize all aspects. And you can imagine an aspect of life: work, relationships at work, sleeping, and then sleep issues will come, and then cardiovascular. Then your pressure becomes difficult to control. So mental health is a very big issue. Luckily enough, it's part of the conversation. When you visit us, those are some of the things we talk. Even the way you walk into the room, we are seeing, we are assessing. The way you respond to our questions, we are assessing. The way you are talking to your partner, we are assessing. All these things help us, and that's why at the end of the day, we have a conversation about what are the issues and how do we want. And sometimes we refer you to the specialist, either clinical psychologist or a psychiatrist, or where I feel confident, I will manage you and see. Thank you very much.
I think there's, thank you. I think one questions from you, sir, that we didn't address. Sorry, I've forgotten the name. So, getting results, one person says, thyroid is not okay, seeing a senior, physician or consultant. So I would really want to, I think that was very unfortunate. That's how I would want to start off. Because even when we arrive at a conclusion that, these are likely, psychosocial issues, I shouldn't just say, you man, you're stressed, go. I should be able to help you. Okay. And usually psychosocial issues, we call those, diagnoses of exclusion, because we don't have a lab test to say this man is stressed, okay? But after we've listened to the story, we've examined, we've ordered some tests, and there's nothing. And as Dr. Lusige is saying, our examination assessment starts from when you're walking into the room, okay? And the way you're talking and the way we are interacting, all that is part of the assessment. So once we arrive at that conclusion, it doesn't mean, because you'll not be able to handle it on your own, okay? This is for us, but it also goes to the people we look after. It's quite common these days, a parent comes saying, this girl also, you need to be able to help her, okay? Because if you don't, it will only get worse and worse. So I must say that was unfortunate. If someone determined that this was stress, then they should have helped you, either themselves or give you the appropriate referral. You know, there are many support services. It doesn't have to be a doctor. We have social workers, we have ETC. So we should be, ideally, we should make that connection for you to deal with a stress rather than saying, just go away. Lab results, even if I don't trust them in front of a patient, I shouldn't say, can I trust them? You know, I must say that is all unprofessional and very unfortunate that it happened that way. If I have a reason to not believe those lab results, I should be able to discuss it with you professionally. If I think we need to repeat, we should do it, but it should be a professional journey rather than, you know, making you feel worse than where you started from. Thank you.
I think lastly, I should make a comment on this particular subject. Dr. Rozige, you know, we have dealt with some of these cases at Nakasero Hospital, the manner in which some doctors talk to patients. It's an extremely important subject because when a patient comes to you all the way where he has come from, he's stressed. He's not in his normal mental status. But when he comes and tells you and then say, no, that this is rubbish, throw it away and go out, it's most unprofessional, very, very, very sad. We've had some of these cases and we've had to deal with them, that when a patient comes, you should listen to them and calm yourself down. Whether the patient is shouting, because that may be part of the problem that he has. You should cool yourself down and listen to the patient. Listen to them, and the manner in which you communicate to them has got a lot of impact on what they go home with. So you've got to be very, very, very careful. If the results were not good, it's not his fault. It is the fault of the doctor who gave them to you and did not explain to you. So it's up to him to try and explain to you what has happened, but the manner in which you were handled, I think, is very unfortunate. And we do dismiss it. As we close, Mr. Chairman, I just wanted to mention one thing. We gave each of our presenters 20 minutes to present, and we had hopes that the question and answers would take about 10 minutes and 15. But I think the manner in which this has turned out seems to be that we should give the presentation again, maybe 20 minutes again, but give a lot of time to question and answers. Colleagues, the audience we are dealing with is not an ordinary one. They come from Lower area and surrounding areas. They live in that area, but in fact, they're spread all over the country. They have got access to internet, so by the time they ask you about cardiac arrest, they already has a lot of information from. So they have a lot of questions, and I think next time we should try and see whether we can allot questions and answers more time. Second, about Google and internet. You can get a lot of information from Google and internet, but in fact you may not understand them very well. So coming to sessions like this and you raise these questions is very important. We clarify what might not have been clear to you when you read some of these things on internet. The same thing when patients come to hospital these days. You sit with a patient in front of you, you start very gently, you go down, and before you know what is happening, he actually has got more information about his condition than you. So you have to be very, very cautious. The way we deal with the patients these days, you just listen and make sure that you explain, not telling lies so that you can go away quickly. No. You must not misunderstand the fellow before you, because he may know more about the subject than you do. So what I'm saying, Dr. Rozige, Nakasero Hospital does a number of corporate social responsibility services. And this is one of them. During those days when we used to work, I think we had offered that service every time we worked, would come and be taught by the nutritionist and other people talking to us. But I think this shows us that we probably should be a little more regular here. Maybe every every 3 months or every 6 months. I don't know how frequently, but I think we should do that. And these people are here, you know, every 15 minutes when they see a patient, I don't know how much they're paid. But they definitely have missed out on what they should have earned, but I think they'll be willing to come and offer that again. So I want to thank my colleagues for having sacrificed your time. Not just time, but your money as well. But it's what they have received and what they have achieved from this is more than what the money would have earned. And I think we value that. So, Mr. Chairman, over to you. And we thank everybody for having turned up to listen to us. But some people said you already know them. So, but we can, I think we can, there's going to be a one-on-one interaction so we can exchange addresses. Oh, there was a question which was not answered.
Yes, I wanted.
And it's a recognizable condition. Having body itching after a bath, especially so cold water. Am I right? Well, I leave you to the consultant that will touch with. But thanks very much indeed. That will be handled between you and the co-doctor.
Yeah. Well,
thank you.
Yeah, thank you so much, Dr. Ben Bonye. I just wanted to request the doctors to just give us a few minutes, parting shots, key things that they would like us to go with, and then I'll call our chairman, Joachim, to give a vote of thanks and to also pray for our chai, which is getting cold. And then we'll go out and interact with the nutritionist. Yes. Yes, so please, your parting shots, Dr. Watia.
Thank you very much. So my final one is that it's a takeaway message actually, is that prostate cancer can be helped at whatever level. It can be treated, but the one we like to treat best is the early one. And the early one, the only way or the best way of picking it up is by checking. That means checking early and therefore participating in all these screening tests or screening programs is a good way of picking up early cancer. And also to tell you that at the moment we don't have actual way of preventing it, but we have a way of treating it, of diagnosing it and treating it early. So early treatment, early diagnosis, early treatment is the way forward. But even if it has moved out of that stage, it can still be treated. It can be treated. So we can, at whatever stage, and even when it has become resistant to drugs, there are many other drugs that can come on board, and the oncologists work hand in hand with the urologists to make sure things keep running. Actually, cancer, I want to tell you, is usually not a treatment by one person or one specialty. It is usually a treatment by many specialties. We come to, it's multidisciplinary. We come together and then we make several suggestions and then we treat. And many times when the diagnosis is made, it is put to what we call a board. The board, and then we interact, we discuss, and see the way forward. But we also value the decision of the patient. Okay? When it comes to treatment, especially when it comes to chemotherapies and all the like, we value the decision of the patient, because also our treatments have issues. And we discuss frankly about those issues so that the patient can have an informed decision. Thank you very much.
Yeah, thank you very much, Dr. Watia. My conclusion is that we have several things that are within our means. Several things where we can act and make a difference in our lives and be able to prevent today's actually leading, internationally leading cause of death and disability, which is cardiovascular diseases. So if we can address those, then we can leave chance to those that are not within our means. But just the take-home message is we can be able to do something to prevent. Thank you.
Thank you so much. In the same breath, I would like to thank you and also thank my colleagues here. My take-home message is going to be that let's work together. As Nakasero Hospital, we promote this concept of patient and family-centered care. So we really encourage a lot of patient and family engagements, especially in some of these very complex conditions. We've seen families support the patient. Families have supported us in helping make the right decision for the patient, together with the patient. So we don't work for the patient. We rather work with the patient and the family. That is what I would like to emphasize, especially in these chronic conditions. I don't want to lie to you that that is a good idea of me working for you, deciding for you. Quite often I may not understand you better than you understand yourself. So we really want to promote the concept of working with the patient and the family so that we make the best. And so take note of that and take note of the scheduled visits. If you have not made one, please make one, because that's the time you have and that's the time I also have to quickly see how we can work around to identify, screen and diagnose anything that is treatable, including diabetes, hypertension, cholesterol issues, thyroid issues, even the autoimmune conditions that we're talking about. So we make a big difference if we schedule these visits and pick up these things. Let's not wait for the symptoms. I think it's better, and I'm sure not planning is failing to what? Failing to plan is what? Is planning to fail. Is that what they say, the strategists? The same thing applies. Actually, most importantly, health is an investment. So let's take a look at it as that, and the return on investment is going to be almost equivalent to the way you planned for it. So let's take time to plan on it, because the return on investment for health is big from a personal angle, but also from a society angle and the family. Thank you.
Thank you so much. May we give them a round of applause. We really appreciate Nakasero Hospital management, Dr. Ben and your team for sparing time to educate us these important health issues that we face. I am quite sure that most of us have got a lot of information, and we still have questions that we'll need the team to address, and we've been given an opportunity to meet them and, get, answers to the questions that we might be having. Thank you once again. We do appreciate, and our request is you spare time and come again and give us more information about these issues that we face. Isn't it? Yeah. Thank you once again. Thank you so much. Yes? Amina. Two things that I've got from this talk: early diagnosis, early what? Treatment. So please, let's ensure that we build a routine of checking, having this regular check so that we can arrest these situations. Yeah, now we're going to pray for our tea, and then we will have tea as we access the other services that are outside there in the tents. Right? Okay, let us pray. Heavenly Father, we bless you so much for this time. Thank you so much for the team that has been here, the panelists. Thank you for the Nakasero Hospital. Thank you so much for enabling them to come and spare time to educate us on these health issues, oh Lord. We pray you continue increasing them, oh Lord. Give them the wisdom, oh Lord, my Master. Give them the ability to impact onto your people, oh Lord, in these areas of health. We bless you, oh Lord, my Master, for the men's program and the committee that has put this together, oh Lord. We pray that, Lord God, you will also bless them immensely. And even for all of us who have attended, oh Lord, my Master, may you continue meeting us at our point of need. We bless so much the tea and the eats that have been prepared. We pray that, Lord, you sanctify them. In the name of Jesus Christ we pray. Amen. Thank you so much. Thank you.
So you cook it.